Good evening, everyone. It's a great pleasure to welcome you all for 3 days webinar Revolutionizing Oncology Pathways to Progress Lung, Breast, GI, Ovary, and Prostate Cancer. Today, we are discussing breast cancer. So, I would like to invite Dr. Tarachan Gupta, sir. Sir is a consultant medical oncologist, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. Over to you, sir. Please start.
थैंक यू वेरी मच। शायद वीडियो मेरा ऑफ है होस्ट की तरफ से। आई थिंक होस्ट हैज स्टॉप्ड माय वीडियो।
Supporting, please switch on doctor's video.
गरिमा, आई थिंक वीडियो
Sir, just a minute, no? We'll check.
या स्टार्ट।
Please start, sir.
Good evening, all the faculties and the audience. Today, I welcome to this crucial gathering focused on breast and ovarian cancer. Today, we unite in our collective commitment for advancing knowledge, fostering collaboration, and driving innovation in the relentless pursuit of better outcomes for those affected by these challenging diseases. Together, we stand at the forefront of the progress where each conversation and idea shared holds the potential to make a profound impact. So again, thank you for your dedication to this vital cause. So without any further delay, I invite Dr. Lalit Sharma. He is a senior consultant medical oncology at Manipal Hospital. He will be speaking on the role of neoadjuvant chemotherapy in hormone receptor positive, HER2 negative breast cancer. Over to you, Lalit, please.
I'm not able to receive any audio. Sorry to interrupt.
घर में भी कोट पहन के ठंड लग रही ज्यादा। ललित,
Okay, sir.
any problem?
Yeah. I was not able to receive the audio. Did I miss something? Shall I start or something?
Sir, your voice is audible now.
Shall I start the presentation?
Yes, sir.
Sorry for the interruption. The job cut out for me for today's evening is to discuss the role of neoadjuvant chemotherapy for a hormone positive and HER2 negative breast cancer scenario. So during this particular presentation, we would intend to move through various questions. First is, why should a patient receive a neoadjuvant chemotherapy? Who are the eligible patients for this intervention? What should be the given agent for this particular intervention? And whether the response after the neoadjuvant chemotherapy changes or adjuvant treatment. Moreover, what are the current recommendations for the same? Now, the first question we would like to answer is, why should a patient receive neoadjuvant chemotherapy? The primary tumor, where we find if inoperable, tends to the objective is to make it operable after a neoadjuvant intervention, be it chemotherapy or the hormonal therapy. Even in patients who have a large operable tumor but unfavorable breast to tumor ratio, neoadjuvant intervention helps us convert the patient to a breast conservative scenario. Now, in patients who present for BCS and are candidate, even better margins of negative resection can be achieved after a neoadjuvant intervention. Moreover, low target volume excision, simple level 1 OPBS, and the cavity boost dose can be achieved. This also allows us for targeted axillary sentinel lymph node dissection, hence reducing the surgical complications because of the extensive axillary lymph node dissections if the patient undergoes surgery before the neoadjuvant treatment. Now, it also allows for planning the breast reconstruction even in patients who are electing for mastectomy but opt for a reconstruction, the primary reconstruction itself. This also gives us, based on the primary and the axillary response, the chances to measure the disease burden, to study the disease biology, and better decide appropriate adjuvant therapy. Now, this was from a medical oncologist point of view. From a surgeon's perspective, also, this helps us to identify more and more patients which are eligible for a BCS. As per the randomized controlled trials, the incidence of BCS increases after a neoadjuvant intervention from the tunes of less than 50% in upfront surgery versus 65% after a neoadjuvant intervention. So, who are these patients who would be eligible for neoadjuvant chemotherapy? Usually, it is the scenario of locally advanced breast carcinoma, wherein either the nodal burden is more, or if the tumor size is on the higher side. Even in scenarios wherein the tumor size might not be that large, but if it is inappropriate in the sense that the breast to tumor size ratio is low, the neoadjuvant intervention might help us achieve a BCS after the initial intervention. Now, there are several factors to be considered before we opt for neoadjuvant therapy. Two things: whether neoadjuvant therapy, and the second, what adjuvant should it be or hormonal. So the three features which we need to take into account is tumor burden, presumed responsiveness to prime therapy, and the patient's age. Tumor burden is defined by what is the tumor size, what is the grade of the tumor, what is the ERPR and HER2 status, and whether what is the status of Ki67, which is a marker of proliferation. Usually, patients who are more responsive to chemotherapy are the ones which have either high grade of tumor, that is high Ki67, weak ER and PR status, unfavorable signatures such as MammaPrint or Oncotype DX, and a luminal B or surrogate, and the patients who have features which are marker for early recurrence. So a larger disease burden, a more aggressive variant, high grade with high Ki67 probably might respond far better to chemotherapy as compared to the other contrast, the patients on the other end of the spectrum, which are a low grade, low Ki67, strong expression of ER and PR with an favorable signature status. So this is what was depicted in the CT-NEO-BC pooled analysis, wherein we saw that patients with high grade of tumor achieved far better pathological response rates to the tunes of 60% versus those who had low grade breast carcinoma. Almost half of the pathological response rates were to the tunes of half. So even if the overall response rate was better with the neoadjuvant chemotherapy, it was seen that in patients who were hormone positive and HER2 negative, they showed far better response as compared to and high grade IDC showed far better responses. Similarly, patients with luminal B or surrogate expressions showed far better response as compared to patients who had a luminal A expression or luminal with B with HER2 positive expression. Then there was the study which was published in 2017, which tried to evaluate whether these molecular markers or the risk panels which we use help us guide what kind of neoadjuvant intervention, be it the chemotherapy or hormonal therapy, would show better responses. Here, the patients were divided into three categories. That is, one with low risk scores less than 11, the other more than high risk scores, that is more than score of 25, and the intermediate ones were further divided into the neoadjuvant hormonal therapy and the neoadjuvant chemotherapy arms. So by the end of when the results were published, we were able to see that the patients who had high risk score responded far better to chemotherapy as compared to the hormonal intervention, whereas in the patients who had intermediate risk scores, patients with higher Ki67 showed far better responses as compared to those with a low Ki67. Now, what should be the neoadjuvant chemotherapy regimes which can be used? Probably NSABP 18 was the first trial which assessed patients for this particular intervention, wherein patients were divided into upfront surgery followed by anthracycline-based chemotherapy for 4 cycles, whereas for neoadjuvant chemotherapy. Anthracycline based followed by surgery. Patients were stratified for age, tumor size, and nodal status. And the key principles or the key results were that the higher clinical response rate was seen, and the pathological clinical response rate was around 13%. The rate of lumpectomy improved after neoadjuvant intervention, and there was a significant downstaging of the axillary lymph nodes to the tunes of 58% versus 40%. However, the study was not able to establish any disease-free survival or overall survival advantage. However, significant clinical correlation between pathological CR and the outcome was seen in this particular trial. Similarly, ABC, that is anthracycline in breast cancer trials, examined the effect of TAC regime versus limited taxane and cyclophosphamide combinations in various trials, and they also examined the uh, standard AC 3 weekly followed by weekly paclitaxel versus dose dense AC followed by weekly paclitaxel and dose dense AC followed by dose dense taxanes. And the results did let us know that the observed hazard ratio for the event-free, disease-free survival on the basis of intention to treat analysis for 6 cycles of taxane and cyclophosphamide did achieve the non-inferiority threshold. That is, in selected patients, uh, lower intensity of chemotherapy also helped us in the similar manner. However, an unplanned test for interaction by combined hormone receptor status and nodal status demonstrated that a significant interaction for positive hormone receptor status, but no interaction in the patients with hormone receptor negative status was seen. That is, in patients who were hormone positive but node negative, the overall disease-free survival was not that good with neoadjuvant intervention. Similarly, there was this another trial which evaluated treatment with neoadjuvant nab-paclitaxel. So, by the end of this trial, what we came to know was that nab-paclitaxel versus paclitaxel, though nab-paclitaxel did give us far better or slightly more chances of pathological CR, but this achievement of pathological CR did not transfer to any PFS or overall survival advantage, and the this pathological CR which was achieved was not statistically significant also. In various trials which have examined the dose dense versus standard 3 weekly regime of anthracycline based regimes do show us that dose dense regimes have lesser recurrence rate versus the standard 3 weekly and lesser mortality rates also. These results also show us that the proportional recurrence reduction was similar in both the ER negative and the ER positive breast cancer, but the absolute reduction in the 10-year recurrence was somewhat larger with the ER negative disease rather than the ER positive disease for those dense versus the standard chemotherapy regimes, which probably might give us or might help us understand that in the borderline tolerability scenario, we might not opt for dose dense therapy where toxicity is a huge concern in ER positive patients, especially in the elderly patients. Was this study which tried to examine whether neoadjuvant chemotherapy, how the neoadjuvant hormonal therapy fared as compared to neoadjuvant chemotherapy in the postmenopausal females. And as we can see here in the results, that the overall response rate was somewhat better in the neoadjuvant hormonal therapy arm, and the it was clinically significant also. So, in patients who are elderly, have we have do have concerns of giving chemotherapy due to either performance status or comorbidities. These might be eligible for neoadjuvant endocrine therapy also. Then there was the study GEICAM conducted from 2006-03, which did let us know that this neoadjuvant intervention did in the form of hormonal therapy did work well for the postmenopausal females and in patients who had a low Ki-67, but was not that fruitful in premenopausal scenario. Rather, it was the response rates were far lesser, especially in scenarios wherein the Ki-67 was more than 10%. So another question which we need to know is whether this the responses to adjuvant chemotherapy does help us modify our adjuvant chemotherapy interventions. So, CREATE-X was the trial which studied patients who underwent neoadjuvant chemotherapy followed by surgery and who did not receive PAT-CR. These patients were divided into observational arm and a experimental arm which received capecitabine, and the addition of capecitabine in the adjuvant treatment did show us significant improvement in the disease-free survival and overall survival also. So, to conclude, what are the recommendations at this point in time for neoadjuvant chemotherapy? As per the ESCO guidelines, neoadjuvant chemotherapy is the treatment of choice for patients with inflammatory breast cancer or those with unresectable or locally advanced disease at presentation or whose disease may be rendered resectable with neoadjuvant treatment. The tumor histology, grade, stage, and estrogen, progesterone, and HER2 expression should routinely be used to guide clinical decisions as to whether or not to pursue neoadjuvant chemotherapy. Neoadjuvant systemic therapy may be offered to reduce the extent of the surgery, that is, breast conservation and axillary lymph node dissection. Chemotherapy with or without targeted therapy or endocrine therapy may be offered. Patients receiving neoadjuvant therapy should be monitored for response with clinical examination at regular intervals, and even radiological examinations which were done prior to starting the neoadjuvant chemotherapy may be repeated at the end of neoadjuvant chemotherapy. Neoadjuvant chemotherapy may be used instead of adjuvant chemotherapy in any patient with hormone-positive, HER2-negative breast cancer in whom the chemotherapy decisions may be made without surgical pathology and/or tumor-specific genomic testing. For premenopausal patients with HR-positive, HER2-negative early-stage disease, neoadjuvant endocrine therapy should not be routinely offered outside of a clinical trial. So, to conclude, neoadjuvant chemotherapy is beneficial in luminal B or high-risk luminal A for breast conservation surgery. Clinical pathological features are still the best prognostic or predictive tool. Gene expression signatures shall be used very cautiously in young premenopausal females, and it is not yet validated for neoadjuvant endocrine therapy. Anthracycline and taxane-based chemotherapies are the treatment of choice. In high-risk node-positive disease, choice. Benefits of downgrading dissection, increased chances of breast conservation surgeries, more chances of achieving PR. The role of breakthrough not yet clear in the current setting. Thank you. Thank you for hearing.
थैंक यू ललित। मेरे को लगता है तुम्हारे लेक्चर के बाद लोग मतलब बुक पढ़ने की जरूरत नहीं है शायद। अर्ली ब्रेस्ट कैंसर ऑफ न्यू एडजुवेंट कीमोथेरेपी पे अगर यहाँ पे कोई रेजिडेंट्स भी बैठे होंगे तो शायद उनके लिए ये एक बेस्ट लर्निंग वो था सेशन जहाँ तुमने यू एलोबरेटेड ब्रीफली अबाउट द ऑल द एस्पेक्ट्स ऑफ न्यू एडजुवेंट कीमोथेरेपी इन early breast cancer hormone positive. Now for the next talk I invite Dr. Satvik Khaddar. He is a consultant medical oncology, SRJ CBCC Cancer Hospital, Indore. He will be speaking upon a role of OFS in early breast cancer and duration of endocrine therapy, which is also a most worrying question in hormone receptor positive early breast cancer patients. So, Satvik, please.
Thank
Yeah.
you, sir. So, just a minute. So the full screen is visible.
Yes, sir.
Okay, so I'll be talking about the role of ovarian function suppression in early breast cancer and the duration of endocrine therapy. So just to give a little bit of background, we know that adjuvant endocrine therapy with tamoxifen has been recommended for premenopausal patients since last more than 20 years. However, the earlier trials had some lacunae in terms of non-selective inclusion criteria, like they included both ERPR as well as ERPR negative patients. And that is why the earlier ESCO guidelines, that is the 2011 guidelines, advise against the routine use of ovarian suppression in adjuvant treatment in premenopausal women. Also, it was noted that chemotherapy-induced ovarian suppression correlates with the reduced risk of relapse. However, this effect was less pronounced in younger women. So that again, because of this, the idea of OFS was not clear in the earlier days. And also the adverse prognosis of very young premenopausal women with ER-positive breast cancer and the correlation between the lack of treatment-induced amenorrhea with younger age led to the ongoing uncertainty regarding the potential role of adjuvant ovarian suppression. And in fact, the demonstration of superior efficacy of adjuvant endocrine therapy with AI versus tamoxifen in postmenopausal females indicated that there is a potential value in studying this regimen even in premenopausal women. So considering these 2 points, the IBCSG, that is the International Breast Cancer Study Group, in 2003 initiated two randomized phase 3 trials. One was SOFT and the other one is TEX. Both are landmark trials. The SOFT was suppression of ovarian function trial, and TEX is the tamoxifen and exemestane trial, which involved premenopausal women with hormone receptor positive early breast cancer. The idea behind these two parallel trials was slightly different. The SOFT was designed to determine the value of adding ovarian suppression to tamoxifen and to determine the role of adjuvant therapy with AI, that is exemestane plus ovarian suppression, in premenopausal women. And the text was designed to compare whether exemestane is beneficial over tamoxifen when both are combined with ovarian suppression in premenopausal females. So coming on to the first trial, that is the SOFT trial. This was the first 5-year analysis published in NEJM in 2015. So this is the randomization and analysis in both the trials, but we'll focus on the SOFT trial. You can see some 3,000 odd patients were randomized in 3 arms: TAM versus TAM plus ovarian suppression versus exemestane plus ovarian suppression. But the analysis, the primary analysis in the SOFT was between TAM versus tamoxifen plus ovarian suppression, and the exemestane plus ovarian suppression versus TAM alone analysis was a secondary analysis. And whereas the TEX randomized patients in TAM plus OS versus exemestane plus OS, and ultimately the TEX trial resulted the combined analysis of both the arms in both the trials. So focusing on the SOFT as of now. So when I am talking about the SOFT trial, we'll be discussing mainly about TAM plus OS versus TAM alone and not the exemestane arm. So the primary endpoint of this trial was DFS in premenopausal patients in among the tamoxifen versus the tamoxifen plus ovarian function suppression. So the above graph shows the 5-year data, and at 5 years there was no difference in the disease-free survival, which was the primary endpoint in the tamoxifen plus ovarian suppression versus tamoxifen. So you can see the 5-year DFS rates were 84.7 versus 86.6 in the ovarian suppression arm, and with the p-value was non-significant. However, if you see the below graph, at 8 years, tamoxifen plus ovarian suppression versus tamoxifen, there was a significant difference in the 8-year disease-free survival, 83.2 versus 78.9. So in absolute terms, 4.2 percent point benefit of disease-free survival at 8 years, which was statistically significant. So what I mean to say by this is that in the initial 5 years, the TAM plus OS arm did not show benefit, but in the later years, it did show benefit, even though the duration of therapy was only 5 years. And this is well known with hormone positive breast cancer, that the effect lasts longer than the duration of the therapy. So coming on to the subgroup analysis, you can see overall disease-free survival benefit was there, but there were some subgroups, particular subgroups which benefited more than the others. And if we look at the age, patients less than 40 years of age and specifically less than 35 years of age benefited the most. Higher grade tumors benefited more, and patients who received prior chemotherapy, they benefited the most. So, but recently, after 8 years, the 12-year results were also published in JCO in December 2022 of SOFT as well as TEX trial. Coming on to the analysis of the SOFT, you can see the 12-year DFS rate was statistically as well as clinically significant between the TAM plus OFS versus tamoxifen arm. So it was 76% in the tamoxifen plus OFS arm versus 71.9 in the tamoxifen arm. So approximately 5% point benefit. And if you yeah. And the if you see the overall survival also, you can see there was a trend toward survival benefit. However, it was not statistically significant, but the p-value was 0.06, just borderline. And in absolute terms, there was some 2.2% overall survival benefit. So again, the 12-year data also supports the 8-year data that even after 12 years, the difference in the disease-free survival was evident in the tamoxifen plus ovarian suppression arm, with a hint towards survival benefit also and the longer follow-up. So because they had a slightly like marginal survival benefit in the tamoxifen plus OFS arm, so they did a subgroup analysis, and by this time, the HER2, they divided the patients into HER2 positive and HER2 negative, because more than 85% of the patients were HER2 negative in the soft and the tech. So they basically analyzed the HER2 negative subgroup, and if you see the subgroup analysis, you can see the patients who have received chemotherapy in the soft, they had a significant benefit. If you see the patients who had received neoadjuvant chemotherapy, close to 12% absolute benefit in the overall survival. This subgroup analysis is of overall survival at 12 years. So there was a significant survival benefit of adding ovarian suppression to tamoxifen, specifically in patients who have received chemotherapy and specifically neoadjuvant chemotherapy. Again, close to 9% absolute benefit in survival in younger patients, that is less than 35 years of age. In heavy nodal burden disease, there was close to 4% survival benefit, and similarly in higher grade tumors. So basically, not all, but these high risk characteristic patients do benefit in terms of DFS as well as OS when ovarian suppression is combined with tamoxifen. Now coming on to the parallel trial, which was the text trial. Coming on to the result of text trial, the first analysis was done and was published in NEJM in 2014. And interesting thing, even at 5 years, as we have seen in the soft trial, at 5 years, TAM plus OS versus tamoxifen, there was no significant difference in the disease-free survival. But with exemestane, you can see even at 5 years, there was statistically as well as clinically significant disease-free survival benefit at 5 years as compared to tamoxifen plus ovarian suppression, 87 versus 91, close to 4% absolute benefit, which was statistically significant. And if you talk about the patients who were again HER2 negative patients, if you ask in the 8 year survival, there was close to 4% absolute difference in the disease-free survival. Coming on to the overall survival, so these two graphs for disease-free survival. Coming on to the overall survival, at 5 years, it was not significant. And even at the right-hand side graph, it shows the 8 year overall survival rate. Again, it was not significant between the exemestane plus ovarian suppression versus tamoxifen plus ovarian suppression. However, coming on to the 12-year data of the text trial, again, DFS was significant, as we have seen at 5 years and 8 years. At 12 years also, DFS was significant in the exemestane arm as compared to the tamoxifen arm. And in the 12 years, you can see there was 1% difference in the survival in all the patients. But if you see this graph, that is the HER2 negative subgroup, which comprised almost 85% of the patients, there was 2% absolute difference, and the has you can see the upper boundary of the hazard ratio was just touching the unity. So again, there was a trend towards survival benefit in exemestane plus ovarian function suppression arm at 12 years. So again, showing that adding ovarian suppression leads to survival in the long term. So coming on to the subgroup, again, they also did a subgroup analysis for overall survival in the text trial at 12 years of follow-up. And again, they could see that there were particular subgroups of patients, even in the text trial, which benefited more. Up to the mark of 4 to 5.5%, you can see patients who were less than 35 years of age had a 4% absolute difference in the overall survival. Patients with a higher tumor size had a 4.5% absolute survival benefit, and higher grade tumors, that is grade 3 tumors, had 5.5% absolute benefit in survival. So, what I mean to say, in the longer follow up at 12 years, both soft and text have shown that not only DFS, but there is overall survival benefit also of adding ovarian suppression, particularly in some high risk groups. Not all patients, but there are some subgroups which do benefit. However, theoretically, it is very easier. It is easy to say that to add ovarian suppression, but as we have all done and we have seen, we have observed that it's easier said than done. There is a high discontinuation rate. There are multiple side effects, the menopausal symptoms which lead to discontinuation, and even in the trial, you can see as the years pass by, this non-adherence rate with ovarian suppression increased from 5% at 6 months to 22%, close to 22% at 4 years. So this was a significant. So close to one-fifth of your patients will stop ovarian suppression at some point of time. And coming on to the final analysis, that is at 12 years, at completion of the 5 years, the rate of early discontinuation was from ranging from 16.7% to close to 23% across all treatment cohorts in both soft as well as tech. So you can see again, approximately one-fifth of your patients will discontinue ovarian function suppression at some point. So there is a need for judicious selection of premenopausal patients according to the magnitude of absolute benefit, which whom can we can offer ovarian function suppression. We should not offer to all. There should be some selection, particularly patients with high risk group,
Hello,
some high
sir.
risk sectors. Hello.
Sir, kindly
Yes.
conclude your talk, please.
Yeah, just few more slides. So, regarding this, a further analysis was done of both the text and the soft trials. There were two publications, one in 2016 and one in 2019, which analyzed this, whether we can select out some high-risk groups which can be offered the ovarian suppression. So, I'll just summarize the findings. And in both the trials, they saw that they did an analysis and they calculated a risk score based on some clinical pathological characteristics. And they saw that patients who had a 10 to 15% improvement according to the risk category, they divided into low risk, intermediate, and high risk patients. So basically, high risk patients had a 10 to 15% improvement in the breast cancer free interval as well as freedom from distant recurrence in both the trials. And these clinical pathological characteristics were young age, that is less than 35 years, four or more positive lymph nodes, and grade 2 or grade 3 tumor. So basically, the subgroup of patients benefit the most when ovarian suppression is added. And they devise the calculator also. This is available online where you can enter the age, number of nodes, tumor size, grading, ERPR expression, and Ki-67, and you will get a composite risk score. So if your risk score comes under high risk, then you can offer ovarian suppression to the patient. If it's a low risk, then you need not offer. And in intermediate risk patient, there is a one-to-one. There can be a one-to-one discussion. So, as we have seen that these side effects are a major part of ovarian function suppression therapy. So, there was a trial called ESPRA trial, which was done whether we can reduce the duration of ovarian function suppression and see whether it also benefits the patient. So, this was the ESPRA study design where they randomized patients into tamoxifen of 5 years with goserelin of 2 years versus tamoxifen alone. And again, the primary endpoint was DFS. I'll just summarize the findings. So again, in this trial, there was a significant benefit in the 5-year DFS rate as well as the 8-year DFS rate in the TAM plus OFS group. So addition of 2 years, even of 2 years of suppression to TAM significantly improved DFS as compared to TAM alone. This is the 8-year data. Again, there was a prolonged benefit of adding ovarian suppression to
So I
tamoxifen.
think we are already overshooting. Please try to
Just two to three
yes,
says. So this is the meta-analysis which was done again, combining 4 trials of close to 7,000 patients, and this showed that adding an AI rather than tamoxifen benefits the patient. And this is again, I'll just skip this meta-analysis. This is the recent which was presented in ASCO 2023. This is a meta-analysis of 15,000 trials, 15,000 patients, and they also concluded that there is an absolute gain of close to 12%, 15-year gain of 12% in patients who receive ovarian suppression. So I'll just skip the atlas then. And so still, there are some unanswered questions. Can ovarian suppression replace adjuvant chemotherapy in intermediate risk endocrine patients? There is a trial which is now being designed, however, it is not yet started. And what is the ideal endocrine regimen? I'll not discuss this in the interest of time. So just to the final slide, as per the guidelines, tamoxifen for 5 years is the category 1 recommendation. Ovarian suppression as per the risk category, and whether you can continue tamoxifen for 10 years is optional. It's category 2A, and equal weightage is to the no further endocrine therapy because there are some drawbacks of Atlas trial. So this is, or you can use AI for 5 years also along with ovarian suppression. So this is the last slide. So in clinical practice, we should give ovarian suppression to patients of less than 35 years of age, higher grade, as well as higher nodal status. And AI plus ovarian suppression is better than TAM plus ovarian suppression, but we can give either of them based on the side effect profile. Thank you.
Thank you, Satvik. Now, now next is the panel discussion.
Sir, kindly unmute yourself.
Yeah. Now I invite Dr. Lalit Mohan Sharma sir to moderate the panel discussion on hormone receptor positive early breast cancer. Sir is a senior consultant in medical oncology and hematology and also in charge of pediatric oncology in Mahatma Gandhi Hospital, Mahatma Gandhi Medical College and Hospital, Jaipur. So for this session, I invite the panelists Dr. Sudhir Palsania from Shalvi Hospital, Jaipur, Dr. Ankur Punia, Mahatma Gandhi Hospital, Jaipur, Dr. Abhinav Jawar, Aurangabad, Dr. Mohit Saxena from Delhi, and Dr. Mukesh Rania, medical oncologist from Jaipur. Over to you, sir, please.
So, very good afternoon. Can I have the slides, please, from your end?
Good evening, sir.
Yeah, very good evening. Can I have the slides from your end?
Yes, sir. Yes, sir.
Okay, can I run from my side, Garima?
Pardon?
Yes, Gitika, please start.
Yeah, okay. So, can you make the slideshow? Yeah, thank you so much. So, warm welcome to all the panelists. Dr. Sudhir, Dr. Ankur, and Dr. Mukesh are from our local young budding medical oncologist. Dr. Abhinav and Dr. Mohit are the foreign faculty for us. Dr. Abhinav is from Aurangabad, Dr. Mohit is from Gurgaon. So, welcome you all, and let us start the discussion. Dr. Tarachan, you will give us 25 minutes or less?
Sir, as per your choice.
Okay, thank you.
25 minutes already allotted, sir. So you can use it.
Thank you so much. Thank you. So let me start with Dr. Mohit. Mohit, thank you so much for joining. So can you tell us that if you see a patient, these are the factors commonly we encounter which predicts or the risk factors for recurrence. So any inputs on these, any other point you want to add or you want to say something?
Sir, I think this is already summarizing quite well. And of course, I am not foreigner, sir. I am basically from Rajasthan. But so all factors which are given are quite, I think you have covered everything. But our point is that just in our setup, Indian patient means are having the breast cancer at earlier age, they are more aggressive. So point which I many of time thinks that whether we should always rely on gene expression profiling or not, that I think that's feels relevant for me, because many of our patients are young, they are having aggressive biology, high grade disease. So we should still follow the Western guideline and offer the oncotype DX to them or not. That's what I many of time think.
Thank you.
Otherwise, the points are, I think, well taken.
Thank you. Dr. Abhinav, can you say something about how often you use the gene expression profiling in clinical practice? Dr. Abhinav, can you unmute? Geetika, is Dr. Abhinav there?
Sir, no.
He's not there?
No, sir.
Okay. So, Dr. Sudhir, can you tell me, you are working in a private setup. So how about how commonly you go ahead with the gene expression profiling?
Yes, sir. As Dr. Mohit sir said, this is the main problem in the Oncotype DX and the Western data. There, the younger patients are there, and the aggressive biology. But we use the Oncotype DX, and there is the newer is the Indian is the cane assist. That in the trial there is the more younger patients are there. So we can use the oncotype DX also, and if the disease is not much burden is there, nodal disease is not there, then the oncotype DX is also correlate with the Indian patients.
I think that is very important that we have the Indian version of the Oncotype DX, and if not possible for us to use the gene expression profiling, probably that is one important step which we can use it. Dr. Ankur, how commonly and which is the subset where you advise for this gene expression profiling by oncotypes or by the Can-Assist? Which are the patient profile?
First of all, the patient who can, afford the test, and
No,
most likely the patients who are, in early stage,
yes.
breast cancer patients, little bit older patients, whether we have to decide, because most of the we have seen that premenopausal patients don't benefit much from the gene expression profiling. So mostly postmenopausal women, early breast cancer, in whom we can think of, avoiding chemotherapy. In those patients, yes, definitely.
Right. So I think these are very, very practical points which my all panelists have discussed. Next slide, please. Now, Dr. Mukesh is there. Mukesh Rulani, are you there?
Yes, sir. Yes, sir.
Can you unmute? I want to see your beautiful face also. It doesn't connect me, in fact, if I don't see the face. Yeah. So, in fact,
1 minute,
these are the factors. These are the factors based on which we choose the adjuvant therapy. So, Dr. Mukesh, can you tell anything other than these?
Yes, sir. So, I want to add one point again. HER2 expression with expression again affect HR positive patients.
I think that is very important that in hormone receptor positive, since the topic given to me was purely on early breast cancer of HR positive. So, but again, that is very valid point.
Yes, sir. HR positive with HER2 positive or HR positive with HER2 negative.
Right.
Because treatment is different and prognosis is also different.
Agreed. So, next slide, please. Next slide, please. So, these are like we have discussed about this also. So, next slide. Can we have next slide? Yeah. So, in fact, these are the points which I felt are very important for us. So, let me start again with Dr. Mohit. Now, Dr. Mohit, which is most important point out of all these things written to you as a hormone receptor positive HER2 negative early breast cancer patient?
I think the latest development in this is the role of the targeted therapy, that is abemaciclib. That we think that we should be aware of that whether the patient is fitting in the criteria of Mona Lisa E, then we should give the option of adding abemaciclib to the endocrine therapy, and that will change the outcome, improvement of the disease-free survival, which I think hazard ratio of around 0.59 or something. So that's what I think that is the latest development. That is the most important thing which I feel. But of course, the patient should fulfill the criteria of the high risk for the Mona Lisa E. That is the 4 or more node, or if the node are 1, 2, 3, then either KCT7 more than 20%, or say high grade 3, or the size more than 5.
Yeah, very true. So this is monarchy, in fact, Dr.
Oh,
Sudhir.
sorry, sir. Sorry,
No,
sir.
no issues. In fact, the
Just,
people may not be happy by listening Mona Lisa from you.
oh, sorry, sir. That's
So,
just.
so Sudhir, can you tell us about which patient, which subset of patient you offer the CDK4/6 inhibitor, whether patient is affordable or not, that is secondary, but which is the subset of patient you would like to put them on?
Sir, I read this about, I don't use about any abemaciclib, but I feel there is the more side effects like febrile neutropenia in 20% patients in their trial, with the only high end benefit around 8 to 9% only. So it is to be seen there the way you can use this freely in the Indian patient population, but there is if any aggressive tumor is there and or N3 and very young, then we can use the abemaciclib. And there is a definitely benefit around the patients around 7 to 8% with the AI, but there are more side effects and more things are there. So we use judiciously only for this abemaciclib adjuvant.
So, Dr. Ankur, in clinical practice, say forget about the affordability and Chiranjeevi scheme, which subset of patient you will offer the CDK4/6 inhibitor in our practice?
So as already Dr. Mohit, told it that high risk subgroup. I think that is the subgroup which benefits more from the CDK4/6 as seen in the Monarchy study. Ribociclib, they did the Natalie study, but they sort of diluted by taking all those patients from early stage, low risk, and everything. So I still think the best is the subset which is defined by that Monarchy high risk subgroup. Those patients have a definite improvement and a very ongoing improvement. So those patients are the most to benefit from adjuvant CDK4/6 rather than giving blanketly to all.
And how commonly you consider Ki67 in decision making for CDK4/6 inhibitor?
Yes, it is an important marker, though they showed that abemaciclib showed benefit irrespective of Ki67, and their OS data in the recent update, they have shown that the patient subgroup with a high Ki67 had a positive OS benefit, though it's still early days, but it's showing a positive OS benefit. And Ki67 is a very big prognostic marker, though it won't decide us basically just on Ki67 whether to give adjuvant CDK4/6. But yes, for high Ki67 patients, it should be advised.
Very right. In fact, in this trial, like they have considered Ki67 not a inclusion criteria, but they say that since there is like observer variability, and in various studies they documented that the variability between the Ki67 can be from like 3% to 30%. So again, standardization is needed for such thing. But Ki67 high definitely puts these patients at high risk, and these are patients who will have relapse, in fact, early with Ki67 high. We all have witnessed that over many years, the adjuvant endocrine therapy, even beyond 5 years, also we keep seeing relapses. So, in fact, we are definitely searching for somehow to prevent relapse in this high risk population, and especially like Dr. Mohit and Dr. Sudhir has mentioned that the Indian patients, they are having aggressive biology, younger age group, so we need to have a better outcome with whatever we use. Next slide, please. Next slide, please. So, in fact, we can see that even after 5 years of tamoxifen, the relapse rates are higher. And even we can see on the right side, the mortality also keeps like increasing after completion of the 5 years. So 10 years, at 15 years. So somehow, somewhere the cancer cells are lying dormant, which is leading to relapses even in later life. So we need to identify this particular subset of patient, which is more likely to have a relapse. So Dr. Mohit, again coming back to you, that in clinical practice, if the patient has undergone, say, neoadjuvant chemotherapy followed by surgery and there is gross residual disease, does this patient qualify for adjuvant CDK4/6 inhibitor after neoadjuvant chemotherapy?
After neoadjuvant chemotherapy, there is gross residual disease there. Sir, but what are the upfront criteria like the nodes? Means, of course, I can offer only if they fulfill the criteria of monarchy. Otherwise, I will not be able to offer. So I will need to know what is the status of node, the Ki67, the size of tumor. These are all things are relevant.
Very, very rightly said. Next slide, please. So in fact, this is very important that clinically and based on the pathology report, we can see higher nodal burden puts the recurrence rates higher. So we can see the uppermost curve where nodal burden is high, the relapses is also high. So at end of adjuvant therapy, endocrine therapy commonly is at 5 years, and then also we can see the higher nodal burden patients are having high relapse. So these are the particular subset which in fact needs adjuvant treatment in addition to the hormone therapy or the AI. Next, please. So again, coming to Dr. Mohit, that you get two subset of patient. One patient has got 3 lymph node positive, it is T2 and 3 lymph node positive, Ki67 less than 20%, and another patient, 1 lymph node with more than 20% Ki67. So which is higher risk according to your assessment?
According to me, it is one node positive with a K67 more than 20% because it is fulfilling the criteria. And one disease and node means and K67 more than 20. So
Very
it is
Ankur, you
fulfilling the
also agree
monarchy criteria.
Ankur, you also agree that this the right side patient is higher risk of having a relapse.
Yeah, definitely, sir. Because Ki67 has a much more bigger impact. And two, still it makes it a higher risk. But if you go by the criteria, yes, then the right sided patient.
Right. Next slide, please. So we can see this slide that the early and late recurrences are happening in patients with various the distant metastasis, locoregional or diseases. So that keeps happening. Next, please. And we all know about early and late relapse. Next slide, please. So this is the important criteria of early breast cancer. And we can see that this is very, very clearly mentioned how we can think of patients with the criteria to fit into the adjuvant CDK4/6 inhibitor. Next slide, please. This again, we have discussed about the T and the nodal effect. Next, please. So this is important that we can see the real world data that more and more like the progression happens with the journey of the patient with even stage 2 also, we can see that the 5-year or 10-year event risk keeps increasing. So more and more time elapses. And again, it is difficult that when should we call these patients as cured? We still don't dare to call them that your disease is cured, and many times after 5 years, 10 years, 15 years, the patients keep relapsing. So we need to identify this particular subset to prevent recurrence. Next, please. Yeah, this is very important. So I think this CDK4/6 inhibitor. So coming back to Dr. Sudhir. Sudhir, can you tell us about various like the Pallas, Penelope, Monarchy, and Natalie? These are the 4 major trials.
Trials for
So
the
what was wrong with the Pallas and Penelope B trial?
sir, they are the Pellas, they are the more the palbociclib and the ribociclib data for the between the 3 trial, but the OS benefit is shows with this abemaciclib only. And mostly the perimenopausal and postmenopausal both patients are there, but mostly they are the node positive patients and postmenopausal in the abemaciclibs.
Dr. Ankur, do you feel that the all 3 drugs are from the same group? So why there have been a discrepancy? Why the 2 trials have not been found to be positive, while the other 2 are found to be positive, Monarch and Natalie trial?
So two things, sir. First, looking at the drugs. As we all know, that this palbociclib came first, then came ribo, and we know as a sort of a newer generation of drug comes, there are slighter modification, they are slightly altered to make them more potent. So I consider like Penelope, there's a palbociclib, the version 1, ribociclib is sort of version 1.25, and abemaciclib is version 1.5. So there are some changes because of the obvious changes which are being made preclinically. Second thing is the difference between this categorization, which you have highlighted, sir, why these drugs failed. Palbociclib might have failed because of 2 reasons. First, in the Pallas trial, why it failed because of the same thing. They took all kind of cancer patient stage from stage 2. They sort of took each and every patient. Penelope study showed some benefit. They took a very high risk score, even higher risk score than the Monarchy study, but the patient number actually was low in Penelope B. For breast cancer trial, 1200 patient no, cohort cannot show any difference. That's why both of these trials failed. Monarchy, yes, is successful because they took a focused approach. Natalie, still they took a sort of mixed approach. but they reduced the dosage, which made it might be more feasible to give the patient for long term. So some these changes might have altered the outcome of all these studies.
So I think other than this, the duration is also important.
Yeah,
The
duration is
duration is
definitely the
also
next most
important.
important thing.
Yeah. Next slide, please. So this again, like we have discussed. Next, please. So this again efficacy data. There is some noise, in fact, in between background. Yeah, thank you. So in fact, this is efficacy data, and we can see the efficacy data in Italy is the latest from ESCO 23. And this all favors, in fact, if we see Netley trial. Next, please. So this is again data from the Monarch E trial. Do you also get some disturbance?
Yes, sir.
So the Monarch E trial, in fact, and even like they had given this drug for 2 years, but the benefit continues for 5 years. So that is very, very important that the benefit continues as the time goes on. So even at 5 years also, this is the latest update that the hazard ratio is 0.665. So it means almost 33% reduction in the risk of distant relapse with the Remivin or the abibaciclib. So that is very important. Next, please. So even the invasive disease-free relapse, also same thing happening, that even the benefit continues for 4 years, 5 years also, and we don't know tomorrow, like after a few years, we may discuss at 10 years also there may be some benefit. Next, please. So this again, the benefit continues that at 5 years, there is 7% improvement in the distant relapse-free survival. So that is very important. Next, please. So these are important questions. Again, I'll start with Dr. Mohit. Mohit, that is there any role of CDK4/6 inhibitor in neoadjuvant setting?
So as far as I know, there is no proven role, because as far as I know about the Corelline trial in which they compared neoadjuvant chemotherapy with AI plus ribo combination, and I think the chemotherapy arm has a better overall response rate. So I don't, to best of my knowledge, I think there is another trial, I think for the Pheline trial, that was also showing the same thing. Adding CDK4/6 inhibitor is not giving any additional benefit. So as far as the neoadjuvant setting is concerned, I think there is hardly any role of CDK4/6 inhibitor to my best of my knowledge as of now.
Yeah, thank you. Dr. Mukesh, question to you. Like if a patient is premenopausal with CDK4/6 inhibitor, you will consider TEM as partner, or you would like to consider aromatase inhibitor as a partner?
So, sir, we will consider in part with.
Can you repeat that, Mukesh? Your voice is unclear.
Yeah, sir. I will consider aromatase inhibitor with CDK4/6 inhibitor as a partner.
And why do you consider, why not TEM in premenopausal?
Especially because we are adding CDK4/6 inhibitors. These patients are high risk patients, so usually we consider OPS with CDK4/6 inhibitor. So with OPS, aromatase inhibitor again shopped in text trial AI is better as compared to tamoxifen.
Right, agreed. Dr. Sudhir, next question to you. The fourth question, young women wants to go for pregnancy. She is on endocrine therapy plus CDK4/6 inhibitor. How do you handle?
Sir, there are the pregnancy for this CDK4/6. There are the minimal data with the endocrine therapy. There is the data of the safety not there for the CDK4/6 inhibitor right now.
You will allow or you will not allow? If a 30-year-old lady comes to you who is willing to go for CDK4/6 plus endocrine therapy plus ovarian function suppression, but she is keen to have pregnancy, you will allow or not?
Sir, with the ovarian function suppression, we should discontinue with the ovarian function suppression and talk about the CDK4/6 inhibitor. There are the role of unknown teratogenicity with the CDK4/6 and explain about that future at the fetus also, sir, for the patient.
Yeah, so in fact,
And
after completion of 2 years of this, we can like plan for pregnancy also. Does any panelist have any comments on this?
So I just want to have one doubt about this. That of course, in the pregnancy, the hormone level will be high, say around the progesterone level and all. So whether we should, if patient is, we should allow, or that's why the question. Of course, in the metastatic, it's not, but well, because it is a hormone positive breast cancer, so that's what I want to
Yeah,
ask.
so in fact, the relapse risk is highest in first 2 years. And you are giving that amoeba or amoeba for 2 years, or if you are giving ribo, then it is for 3 years. So after the completion of that, you can plan for pregnancy if the lady is very keen with added risk. So I think we have discussed most of the things, and my 25 minutes are over. So last comments from Dr. Sudhir.
Yes, sir.
Any comments from your side?
Yes, sir. Now there the recurrence rate are more in the late recurrences are common in these things are for the patients with the premenopausal or aggressive disease. So this is the inclusion of abemaciclib or natal trial are positives for there, and the ovarian function suppression is there with the letrozole, and all that things are becoming more and more important. And can assist is a good thing about the young women if they are the early breast cancer is there.
Agree. Ankur, from your side, just last question that if a lady has got BRCA mutation and she is like deserving for CDK4/6 inhibitor as well, how do you handle that?
So looking at the things, magnitude of benefit is more with the use of BRCA inhibitor. So I will not, combine till we have more data, because as such, there's a very rare subgroup might not even get a data hormone positive BRCA patients. So because the magnitude of benefit with a PARP inhibitor is much higher than seen with CDK4/6, so I prefer a PARP inhibitor rather than giving them CDK4/6.
And when do you sequence the BRCA, the like CDK4/6?
I will not give CDK, I will just give PARP inhibitor if needed. I will not sequence.
Yeah, so in fact, the common guideline, this is a very tricky thing. So the common consensus is that since BRCA is driver mutation, so we give the BRCA directed therapy at least for 1 year, and then we can consider the CDK4/6 inhibitor, but no point in combining these together. And how about with radiation? Dr. Mukesh, do you combine radiation plus CDK4/6 inhibitor? Dr. Tara, your comments on radiation plus CDK4/6?
Sir, my comment, I will comment on this, but just two questions are there. One is how relevant is can assist? And the second is in Natali, they are using 400 milligram ribociclib, and in metastatic, they are using 600 milligram ribociclib.
Yes.
So how the different is the dosing? And should we use in metastatic setting also? That will cut down the cost of the treatment also.
Very, very relevant. So about the can assist has been proven and has been published in like good reputed journal that this becomes like a substitute for the Oncotype DX with limited capacity or capabilities available. So it is not that it is useless. This is useful tool. But again, we need to identify the subset of patient where this will be useful. About the second part, can you repeat that second part? 600 is 400.
Sir, in Nathalie, they are using ribociclib 400 milligram, and in metastatic, that is the 600 milligram dose of ribociclib.
Yes.
So, how the dosing is? Why the dosing is different? And can we cut down the dose in metastatic setting also?
Very, very right, very relevant. So in fact, I was also a partner in this study at Mahavir Cancer that they wanted to compare the 600 versus 400 dose in metastatic setting. Unfortunately, the trial did not get published due to various reasons, but it is documented that even 400 is also like efficacious. For the adjuvant part, since the duration is going to be 3 years, So the complications are higher with 600 milligram. So since they wanted to give it in the adjuvant setting, the efficacy wise 400 and 600 is not much difference. So they wanted to continue this for 3 years without much toxicity. So the criteria in metastatic setting is like we have a disease process which is being hit by this plus the hormone therapy. While in adjuvant setting, we don't have a disease process. So they wanted these females to be like well controlled without much of symptoms, and the efficacy is maintained. So the trial did not get over. In fact, that 600 versus 400. Otherwise, this was a trial designed by the Novartis only.
Yes, sir. And
So
sir, if the lady is 75-year-old with a T3N2 disease and
yes.
75-year frail lady, then and not fit for the surgery upfront because of the frailty, what is the harm in using CDK4/6 inhibitor along with the hormonal therapy in neoadjuvant setting if the disease is not non-metastatic? Disease non-metastatic.
So in fact, like after the age of 70 years, it is individualized treatment. So yes, we can continue the way you suggested. There is no harm in giving the new adjuvant CDK4/6. And in coming few years, we may get cases like we are seeing for HER2 positive cases, where we see for PET CR or pathological response. We will see after a few years that we may get HR plus the CDK4/6 inhibitor neoadjuvant setting, maybe for 4 weeks, maybe for much more longer period, and see what happens. Even trials have been done to see the Ki-67 index. That what happens that Ki-67 from 30% if drops down to 10%, it is good response. So in fact, these all studies are like will take some time, but it has been a great fruitful discussion. So I express my gratitude and thanks to Dr. Tarachan for giving me an opportunity, Dr. Sudhir, Dr. Ankur, Dr. Mohit Saxena, Dr. Mukesh for excellent discussion. With this, we conclude this panel and thank you
sir.
so much.
Thank you, sir.
But sir, one
Wonderful.
thing is there, sir. I feel, sir, there is a radiotherapy part. The CDK4/6 should not be with the radiotherapy because cell
Very,
cycle is there, sir.
very right. So one is cell cycle, other is the toxicity is also
Toxicity,
high.
sir. Yes, sir.
So CDK4/6 inhibitor should not be given along with radiation.
Radiotherapy, yes, sir.
And radiation once complete, then we should add CDK4/6 inhibitor. Very right.
Yes, sir. This feel, sir. I feel. Thank you so much.
Thank you so much. Thank you. Over to you,
Thank
Dr.
you.
Tarachan, as well.
Thank you, sir, for a wonderful and fruitful discussion. Now I invite Dr. Siddharth Tharkar, who is a founder of the Radiant Oncology Center in Raipur. He will be speaking upon the role of neoadjuvant chemotherapy in a HER2 positive breast cancer. Siddharth, over to you, please.
Good evening, everyone. So I will be sharing my slides. So I will be talking on anti-HER2 neoadjuvant chemotherapy options in breast cancer. So we all know that amplification of HER2 gene leads to a biologically more aggressive disease, and it is found in 15 to 20% of all breast cancer patient. And it has been seen that concurrent administration along with chemotherapy of targeted agents enhances the cancer chemosensitivity, and it increases the response rate and pathological response rate. So first I will discuss, because we are talking about neoadjuvant chemotherapy, so what are the benefits with preoperative systemic treatment? So it facilitates the breast conservation because of the response that it shrinks down the tumor. So any inoperable tumor can become operable. We know the prognostic information by knowing the treatment response. And in those patients who have residual disease, we can modify our treatment plan if we know that prognosis is going to be poor. And it also allows time for genetic testing. What are the opportunities with that? We can modify our radiation field. Because of that, we can modify our surgery according to that. So we can have better and better cosmetic and better lesser side effect option for our patient. What are the cautions? because of systemic treatment, we are without knowing exactly the pathology. Sometimes we may overtreat the patient. Sometimes we may undertreat the patient without knowing the exact the staging and the pathological nature of the disease. And there is a possibility that during our neoadjuvant treatment, patient may progress because of non-response to the systemic agent being given, and we may lose the opportunity to operate. So what is the how to evaluate a patient with breast cancer who need to given a preoperative systemic treatment? It is almost same as any other patient. We need to do a metastatic workup. PET is useful in certain circumstances where there is a higher possibility of METs, or there is an aggressive biology like HER2 positive disease or triple negative breast cancer. So in these patients, it is better that we go ahead with complete metastatic workup before starting the preoperative systemic treatment. Now, who are the candidates for preoperative systemic treatment? Patient with inoperable disease, more than 2 centimeter of tumor, and node positive disease and HER2 positive disease. These are basically more and more applied for preoperative systemic treatment. And in this patient we can and on those patient also where we want to delay the surgery for certain reasons. Who are non-candidates for preoperative systemic treatment? Patient with extensive in situ disease when extent of invasive carcinoma is not well defined, patient with a poorly delineated extent of tumor and whose tumor are not palpable or clinically accessible. In these patients, it is better to operate this patient first, because we are not going to know after the response with the chemotherapy treatment. So I'm not going to take much time on this, but neoadjuvant trials with trastuzumab have shown that it increases the PAT-CR rate, and it has been seen that when we increase the PAT-CR, there is an increase in overall survival of the patient. So this is published in JAMA Oncology in 2016, and it has been seen that those patients who have achieved PAT-CR after trastuzumab or whatever chemotherapy we have given, there is an increase in overall survival of the patient. And based on that, it has been a continuous process, or it has been a continuous effort to improve the PAT-CR in more and more of the patient. So to achieve that objective, there was another drug, that is pertuzumab, and other HER2 like lapatinib, that was also being given to improve the survival rate of the patient. So this was the phase 2 study, NEOSPOR study, where they have 4 arms in which paclitaxel was given with trastuzumab along with chemotherapy, and they have seen whether they can omit the chemotherapy, or is there anything that adds up with pertuzumab. So what they have seen, that the primary endpoint of PAT-CR was significant in those patients who have received pertuzumab, and the higher PAT-CR rates were achieved with no increased cardiac events and not much of a toxicity. Then again, there was a cardiac safety trial, TRIFENA trial, in which neoadjuvant trastuzumab and pertuzumab was seen. Again, they have the similar finding that the cardiac safety was there with increased in PAT-CR up to 60% of the patient. So we have achieved from 30% of PAT-CR with trastuzumab only, 60% of PAT-CR with pertuzumab was being achieved. In NeoAlto trial, they have tried with trastuzumab, they have tried the lapatinib. And with this also, they have seen that dual HER2 blockade can lead to higher PAT-CR rates. But when coming, when seeing the data of long-term for overall survival, as you can see, this NeoAlto trial, although the PAT-CR rates have increased, but the overall survival rates was almost similar between all the treatment arms, and it was not significantly different between all the 3 arms. Then this is an affinity trial, although it was an adjuvant trial, but most of the data that we are corroborating that adjuvant and neoadjuvant setting in whichever setting we are giving, it is almost same. So what they have seen in affinity trial, that after giving pertuzumab, adding pertuzumab to the standard chemo trastuzumab treatment, what they have seen, that although the invasive disease-free survival have improved, the overall survival was almost same, 92.7% versus 92%, even after 8 years of follow-up. So this meta-analysis was published in 2023, where they have seen although PAT-CR may be useful for patient management and it is a prognostic marker, it cannot be considered as a surrogate marker in neoadjuvant trials of HER2 positive breast cancer patient. Because it doesn't add to it. So what is the other strategy which can be implemented that is being seen in Catherine trial, that they have given the HER2 based chemotherapy to the patient, and after that those patients who have residual disease were randomized between TDM1 and trastuzumab, and what they have seen, there was not only improvement in invasive disease-free survival but also freedom from distant recurrence, and also there was a statistically significant benefit in terms of overall survival. So this is what NCCN recommends, and it recommends that the preferred regimen in preoperative setting is paclitaxel trastuzumab as well as pertuzumab. But what special they have written, you can see that those patients who have node positive disease, especially based on the affinity trial data, where they have seen that there is an IDFS benefit in those patients who have node positive. So based on that, they are recommending pertuzumab to be given only in those patients who have node positive disease. But for all other patients, giving trastuzumab based chemotherapy is the standard option. And in those patients who have residual disease, you can add TDM1 later to improve the overall survival of this patient. So what is the take home message? That neoadjuvant therapy improves the operability, it improves the pathological CR and gives us a valuable prognostic information about the patient. But still it has not been proven that achieving pathological CR is actually leads to significant overall survival difference in those patients who gets treated beyond trastuzumab in this setting. Thank you. Any question? I'm ready for that.
Thank you, Siddharth. Now we will take the questions in the next panel discussion, which will be moderated by Dr. Rushabh Kothari. He is a co-founder of Oncoogy Center, Ahmedabad, and his panelists are Dr. Rohit Rovello, Jodhpur, Dr. Anshul Agrawal, Dr. Kishore Kumar Kota, Visakhapatnam, Dr. Rohit Swami, and Dr. Neha Rawat from Japan.
Thank you, Dr. Tarachan, for this invite. Can someone share the slides?
Yes, sir.
Thank you. So I believe Dr. Rohit, Dr. Neha, Dr. Kishore, and Dr. Anshul, they are available, right?
Two Dr. Rohit are there.
Rohit Swami.
And Rohit Rebello is also there.
Rohit Rovello and Rohit Swami. Rohit Rovello said,
Most, I think he's not available. I think.
Sir, Rohit Rebello sir is not joined. He is not well.
Okay. Okay. So I kept it more for discussion, means more of questions rather than. So we'll start off with case 1. She's 34-year-old female. No comorbidities, good performance status, presented with metastatic breast cancer, liver mets, bone mets, and lung mets. ER of 7/8, PR 3/8, HER2 negative. SGOT, SGPT were raised 85 and 80, bilirubin 1.5. Blood labs are okay. 2D echo was done, which was okay. Next slide, please. So now we will go with the questions. So Dr. Rohit, any other investigations you would need before planning of the therapy for this patient?
So at present, all the investigation which has been done are sufficient for me to start the treatment, and I like to go for PI C3A and ESR1 in the second line when there is progression on CDK4/6 inhibitors and AI. Only after that I'll go for that PIK3CA and ESR1 mutation analysis. So for me, all investigations are there to start treatment to begin with.
Okay. And you have also answered the second question because you told that CDK4/6 inhibitor plus hormonal would be your treatment
प्रीति
of
को
choice.
ज्वाइन करने के लिए बोल देना, बोले कि नेक्स्ट स्पीकर हाँ लेट होएगा बोलेगा.
Dr. Neha, what would be your
Yes, sir.
treatment of choice? Any thought, any difference of opinion?
Yes, sir. My choice will be AI with CDK4/6 inhibitor. And according to the recent trial with the ESR1 mutation, for that, in case of ESR1 mutation, the PFS benefit is doubled, like that is 12 months versus 6 months. So we can consider that. But my first choice will be AI with CDK4/6 inhibitor.
Okay, so ESR1 mutation generally you will not get in first line treatment setting. It is generally would be for
Yes, sir.
someone who has been
Yes, sir.
exposed to endocrine therapy prior. So CDK4/6 inhibitor would be a reasonable choice. Now this
Yes, sir.
patient is
Yes.
very young and premenopausal. So uh, aromatase
Sir, with
inhibitor.
OFS. Yes, sir, with OFS.
Okay, okay. And any preference of medical, surgical, radiation? Uh,
So
means
medical means medical and
medical.
surgical are equal, but medical can be given. Medical is enough.
Okay. And what would be the regimen generally you would give for medical? Would you
Sir,
use
six
monthly
monthly
dose or three?
leuprolide. Oh no, sir, 6 monthly leuprolide 22.5 dose.
Okay. Uh,
Yes.
Dr. Anshul, any other difference of opinion?
No, sir. I agree with sir, which was discussed.
So what would be the leuprolide schedule and dose of choice for this patient?
So
What
really,
regimen generally would you give?
so the real leprosy schedule is 3.75 mg. It should be given every monthly, which is recommended. But in some cases, we are using three monthly also, but the monthly regimen is recommended.
Yeah. So all the data in breast we have is for monthly, and there is some data that if we give 3 monthly, there are chances that towards the end of third month you may not get ovarian suppression. So preferred choice would be monthly. Sometimes due to logistic, you tend to give 3 monthly, but try to give monthly. That should be the general message for ovarian suppression when we are doing it medically. Any word on radiation-induced ovarian ablation, Dr. Anshul?
Sir, so if the patient is not willing to take leuprolide injections, but radiation-induced ovarian ablation does not give 100% chances of suppression of FSH-LH. So near about 50 to 60% patient may have real benefit of ovarian ablation. Rest patient may have increased, they fail to ovarian ablation.
Okay. Medical or surgical ovarian ablation would be preferred over radiation ablation because radiation ablation is not guaranteed. There are chances of failure, especially when you're giving hormonal treatment alone to a young premenopausal female. I think the fourth panelist, Dr. Kishore. Uh, would you consider this as visceral crisis, SGOT, SGPT of 80-85, and consider chemotherapy, or you are good with CDK4/6 inhibitor?
Per se, I will not consider this ASP-ALT elevation as a visceral crisis, sir. I'm not comfortable with these values, and I will not treat it as visceral crisis. I will treat it as visceral disease, and I will comfortable with CDK4/6 inhibitor.
And what would you generally take at visceral crisis, say for transaminitis point of view, or visceral crisis as a definition? When would you consider chemotherapy and not CDK4/6 inhibitor when patient is in visceral crisis?
Especially with respect to the lung, if patient is so many parenchymal mets and patient has oxygen dependent, then I will consider there should be some compromise of the organ function with respect to disease per se.
with respect to the liver, maybe transaminitis, maybe more than 5 times, maybe grade 3 transaminitis, then I may consider, or else I will not consider. Persiflorniflation usually we will not consider if fluorniflation is there, and if we consider tapping, then after that if patient is not symptomatic, then I'm happy to consider CDK4/6 inhibitor. But even one of my patient who had like multiple lung mets are there. She's an oxygen dependent from the day one of when she presented. But I started palbociclib plus letrozole. She's down the line 7th month. She's absolutely comfortable. She's on regular follow. Even though I may take it as visceral crisis at that time, I am inclined towards starting CDK4/6 inhibitor.
Yeah, so this is important that visceral disease involvement will not exclude usage of CDK4/6 inhibitor, even if there is some transaminitis. We will generally give CDK4/6 inhibitor. So there was a good data from I think right choice trial where ribociclib was given, and even with visceral disease and some transaminitis, they showed that the PFS was better with CDK4/6 inhibitor rather than physician's choice of chemotherapy. And it's rightly said that no one would dare to do a clinical trial in visceral crisis, but everyone has some anecdotal patients who were in visceral crisis and they responded well to CDK4/6 inhibitor. They were given CDK4/6 inhibitor because they were not able to tolerate any other chemotherapy. So that is a
What I think, Rishabh, I think there is a, if the patient is still on a ventilator, I think, or nearby on oxygen or NIV, where we cannot give any chemotherapy in the and visceral crisis, I think the CDK4/6 inhibitors are the right choice. And we have seen the patients also.
Yes, sir, I do.
Tarajan, based on data what we have, we can't say that visceral crisis ideal choice, but tried CDK4/6 inhibitor in patient who was unfit for chemotherapy due to visceral crisis, and obviously not all, but few of them would have done well in long term, as what Dr. Kishore told. And in say, for example, initially more than 3 times SGOT, SGPT, we were skeptical to give hormonal. Now we are comfortable to give at least till up to 5 times. Now this, because we know that efficacy of CDK4/6 inhibitor is good with less toxicity, our comfort, the definition of visceral crisis is also getting modified. So I think CDK4/6 inhibitor would be a good choice in this patient with aromatase inhibitor. Dr. Rohit, this patient has strong ERPR positivity, like 7/8 all-red score and of ER positivity. Suppose this was 3/8 or 2/8 or 4/8, would your decision change? So is there any cutoff where you will feel that now I should go for chemotherapy rather than CDK4/6?
So any expression of ERPR above 1/8, I am okay to go with CDK4/6 along with AI. Definitely, if the ERPR expressions are 2 or 3 or 1, then definitely there are more chances of progression of disease very soon on the CDK4/6 and AI inhibitor. But still, if there is a visceral disease, patient is not in crisis, then I will go for CDK4/6 inhibitors with AI. If it is post-menopausal.
Okay. So, Dr. Anshul, say this patient has SGOT, SGPT of 80, 85 and ER of say 3/8. Still, you would go for CDK4/6 inhibitor, or would you consider chemotherapy? So, is there any thought regarding that a young patient with transaminitis, I would give chemo and then CDK4/6 inhibitor, or something of that sort if ER is not very high, say less than 4/8, 2/8 or 3/8?
So in this case, if the PR is negative, patient is young, ER is very low, 3/8. So I think it behaves like a triple negative. I've seen patient behaving like triple negative breast cancer. So I will surely start with the chemotherapy regimen. I will omit anthracycline. I will give chemotherapy only paclitaxel. For the completion of that, I will start with hormone therapy. If a patient is young, if a patient is more than 60-year-old, then I can think first I can try this combination.
Yeah. So, as Rohit told and as Dr. Anshul is telling that both the approach are reasonably as per guidelines, they are okay. But I also believe that I tend to give chemotherapy if ER is low, especially in young female, and if there is reasonable visceral disease, because probably during the next line, if she doesn't respond, probably she will not be fit for the next line of treatment. But again, what Dr. Rohit told, that you start off with CDK4/6 inhibitor, uh, get imaging done bit prior, and consider chemotherapy in second line is also okay. But I would generally tend to give chemotherapy if ERPR is really low. Next slide, please. Uh, Dr. Neha, any preference of CDK4/6 inhibitor of all three which are available?
Sir, according to the trials, the OS benefit is seen with ribociclib. It should be given, but as of the cost, I usually give in the clinic is palbociclib.
Okay, so considering that finance is not an issue, you would try to give ribociclib.
Yes, sir.
Okay, Dr. Kishore, this patient had liver disease. Abemaciclib always says that in liver disease they are better. So, do you have any preference for CDK4/6 inhibitor?
Yes, no, either ribociclib or abemaciclib, anything is fine.
Okay. Dr. Anshul, this is a premenopausal woman, and ribociclib has maximum data in premenopausal woman. So, would you not give palbociclib and give ribociclib because she is premenopausal?
So, in my opinion, so there's no difference between all the TKIs, all these three inhibitors. So I can give any of them. Palbociclib, I don't have any problem to give palbociclib because the data which was of OS data, I think in that data, 25% of patients are censored at the time of data generation. So the OS which we have not received in that data, but PFS was same in all these three arms, all these three TKIs. So I'm comfortable to give any of the TKI.
Okay. So, message is loud and clear from all the panelists that all three CDK4/6 inhibitors are okay in this situation. Uh, Whether it once you have given ovarian ablation, then premenopausal, postmenopausal will not change your decision. And uh, in spite of visceral disease, all three drugs have worked well, and PFS is similar in with all the three drugs. So I would also agree that we would continue to give whatever is available and feasible for long duration. So a short answer, Dr. Rohit, any preference for bone modifying agents?
So definitely denosumab is preferred over zoledronic acid because of event-free survival with denosumab as compared to zoledronic acid. So I'll prefer denosumab as compared to ZA.
Okay. And we have already discussed regarding leuprolide dose and frequency. So I think we'll move to next slide. Next slide, please. Meanwhile, Dr. Kishore, any preference on ZA or denosumab? Do you prefer or you tend to give either of the?
Usually, either of there is no preference, but some creatinine clearance issues, then I will try to prefer denosumab. Or
Denosumab
else,
would be.
I may be comfortable with either of them.
Okay. So this patient received leuprolide, zoledronic acid, letrozole, and palbociclib, and she progressed after 16 months. So once patient has progressed on CDK4/6 inhibitor, we are considering that this patient is still in good performance status, not in visceral crisis. Do you tend to give chemotherapy or you tend to give next line of hormonal therapy? And what are the factors you generally see to decide whether to give hormonal or chemotherapy? We can start from Dr. Anshul, followed by Dr. Neha.
So in this case, sir, we will do a repeat biopsy and send the sample for PIK3CA testing and ESR1 mutation. If the patient is having PIK3CA positive and ESR1 also is mutated, fulvestrant and so alpelisib I can try. If patient is having PIK3CA negative and patient is having ESR1 mutated, so fulvestrant I will try. And so I will also try in this case exemestane plus everolimus. So if the patient PS is good, I will not go for chemotherapy. I will try all these three options first.
Dr. Neha, your view?
Yes, sir. Yes, sir. First, I would like to rebiopsy and check the hormonal status. According to that, if the status is again ERPR positive, then we can I will assess the ESR mutation in PIK3. If PIK3 positive, then alpelisib and fulvestrant combination and according to the ESR status, I can give. And in this case, also the repeat in second line or subsequent line, I will also consider germline BRCA mutation. So and see the status of HER2 0 or 1 plus or 2 plus. According to that, I can also modify the treatment.
Okay, so PIK3, HER2 low or not, ESR1 mutation.
Yes, sir. And
So
germline BRCA
and
further.
germline. So actually,
Yes.
this patient actually warranted germline testing, which actually I missed while I asked Rohit. So this patient warranted germline testing. So that was something which we could have ordered in extra. And if it was BRCA, then we would have some target also. Otherwise, it at least helps in family screening or so. And as both of the panelists told that in next line of treatment, if patient has good PS and not in visceral crisis, they would try to give hormone treatment again based on the targets available. So, do you do any NGS or focused ESR1 and PIK3A is good enough? Dr. Kishore?
Yes, sir. PSR is good enough, I'm thinking. May not able to get the extra information with census. Maybe PSR is also good enough to see these two.
Yeah, so ESR1 mutation, if present, would generally tell that oral SERDs would be a better choice than fulvestrant, but we don't have oral SERDs available. So probably we would not change much even after ESR1 mutation. PIK3A again, alpelisib is there is issue with toxicity and accessibility both. So maybe exemestane, everolimus, or everolimus would be our poor man's alpelisib kind of thing, and we tend to give. Dr. Rohit, anything to add for second line?
No, I agree with you. We can go with the PIK3CA mutation analysis as well as alpelisib, or if there is ESR1 mutation, then ESRDs, or if both are unavailable because of finances, then we can go with fulvestrant or everolimus and exmestane. So I agree with all of the panelists, and definitely we have to go for hormonal therapy in the second line if there is a good response, PFS of around 16 months with the first line CDK4/6 inhibitors. And we can look for BRCA1 mutation, but I think in the hormone positive breast cancers, the incidence of having BRCA1/2 mutation is less than 5%, but still we should look for BRCA mutation and
And
should
again,
proceed accordingly.
that will be used once anthracycline and taxanes are used. So we're still far to use PARP inhibitor in this setting.
Yeah.
Next slide, please. I think we will
So
move
there are
to the next case. And
Pfizer is running a trial of SARD at present.
oral SERDs.
Oral SARDs.
Yeah. So that is means whatever data is there, it
Their
seems that
criteria is same, like patient should be progressed on any of the TKI plus CDK4/6 inhibitor plus.
CDK4/6. Yeah, so they generally are proposing that if ESR1 mutation is there, then oral SERDs would do better than fulvestrant. That is what all the oral SERDs are looking at, and there is some PFS data at least which says same that if ESR1 mutation is there, then oral SERDs are doing better than fulvestrant. So we'll run through the second case. 32-year-old female, good performance status, no comorbidities, currently metastatic breast cancer, brain only mets, ERPR negative, HER2 3+. She underwent surgery upfront, followed by adjuvant of 4 EC, 4 paclitaxel, radiation, and 13 cycle trastuzumab. After 3 months of completion of trastuzumab, there were 2 nodules in brain, left parietal and cerebellar. Next slide, please. The radiation opinion was taken, and because cerebellar region had significant edema and nodule, they were not ready to give SBRT. Next slide, please. So, in such situation, what would you do? This patient had symptomatic brain mets, and SBRT is not feasible, and disease-free interval is around 3 months from the primary treatment. Patient has received trastuzumab. Dual anti-HER2 blockade was not received by the patient. Let's start with Dr. Rohit.
Yeah, so patient is chemo as well as trastuzumab resistant, progressed within 3 months of completion of adjuvant trastuzumab. So I will go either with CAP-LAP or TDM1. I will prefer TDM1. There is quite penetration in the CNS also with TDM1. With the intrathecal chemotherapy also, I can proceed with TDM1. Or otherwise, we can go with capecitabine or lapatinib.
Okay. Dr. Neha, what would be your choice?
Yes. Yes, sir. I agree with Dr. Rohit, sir. I will also consider TDM1, and if tucatinib is feasible, then we can consider that. But written there tucatinib is not feasible, then TDM1 will be my choice.
Okay. So this patient received 8 months of capecitabine lapatinib because TDM1 was financially not viable at that point of time. Again, after 8 months, she had symptomatic brain-only progression. PET scan was not showing any systemic disease. Patient received WBRT before starting second line, means CAPLAP. Because now there was brain-only progression, she was started on steroids, anti-epileptic drugs, and then TDM1 was started. Post 2 cycles of TDM1, she had seizure, and again MRI showing progression in brain, no systemic disease in PET scan. Now we don't have TDXD, we don't have tucatinib. Means these two drugs are not feasible logistically for patient. So how would you treat in this situation? So I know that this is a tough question, how to treat this patient, but she's 32-year old and she's fit. So, and this is a routine clinical situation we have, which every one of us have faced at some point of time. So what would you do generally in this situation, Dr. Kishore?
Sir, I will prefer she progressed on AC, Pacley, and Pacley also not that much PFS and TDM1 and capecitabine. I will prefer Gem Carbo plus trastuzumab. I may not hesitate to rechallenge trastuzumab. Trastuzumab has some PFS benefit even after rechallenge by changing the chemotherapy backbone. Yeah, I may prefer Gem Carbo plus trastuzumab.
Dr. Anshul, what would be your choice in this
The
situation?
patient have not received his, RT to the brain.
Patient has received radiation before starting CAPE lab.
Okay. Okay, so then feasible with gem carbo. So carbo have brain penetration, so gem carbo.
So gem carbo with trastuzumab or only gem carbo?
So trastuzumab I will add. That Dr. Kishore's advice I follow.
Okay, Dr. Neha.
Yes, sir. Agree with Gem Carbo with rechallenging of trastuzumab.
Okay. Dr. Rohit, any other opinion?
Well, I will disagree because the patient has progressed on trastuzumab. Then what will be the use of re-challenging with the trastuzumab? And the second thing is that if the patient is not having any systemic disease and we have started on TDM1, then why don't to focus on the brain to continue TDM1 and to focus on the brain? Definitely, we had given WBRT. We can add IT-MTX, I think, triple IT with IT trastuzumab and continue TDM1.
I think, Rohit, that IT drugs are more for leptomeningeal disease rather than
Leptomeningeal,
parenchymal
yes, sir,
disease.
only not
ASF is not
drugs.
Sorry?
Yes, sir. Yes, sir.
Agreed,
What you are
but
telling me, let's see.
But
CSF
Gem
meds
Carbo
mainly
and
help in any.
Trastuzumab, what good Gem Carbo and Trastuzumab is going to do in this setting?
So gem carb means because we don't have any choice, gem carbo is the natural chemotherapy counterpart which we will think. Now whether to give trastuzumab or not, there is no good answer to it
No, but my
because
question is TDM1, there is no systemic progression. On brain only progression is there.
so even with K-PLEP there was no systemic progression, but this patient had seizure every time she progresses on brain. So TDM1 it is not helping in her there is increase radiologically and she has thrown seizure. So is there any benefit of containing TDM1 also? That is also a questionable thing. And radiation, because it is less than 1 year and WBRT has been given,
We
so no
can't
one
give.
will be ready to give again most of the time. Again, it is always that two nodules are decreasing and increasing. So it is a tough choice. So there is no single right answer. But gem carbo plus minus trastuzumab is something that we would consider. So ideally,
Sure.
if some SRS or something can be added, that would have been helpful. But because the treatment-free interval from last radiation is less, then everyone is not.
Or we can add
All radiation
Pertuzumab also
oncologists are not agreeing to give.
with
Sorry.
Gem Carbo. Or we can add Pertuzumab also with Gem Carbo and Trastuzumab. The patient is
Yeah.
affordable.
Yeah. So gem carbo with
Pertuzumab, so
whatever targeted.
data is in
Any experience of
pertuzumab
trastuzumab
data is
plus
in
lapatinib both?
metastatic.
Trastuzumab and lapatinib both in combination, has anyone used?
Not used, but seen a patient receiving the same had a severe cardiac toxicity. And I don't think it is of much benefit, though there are studies, there are case reports where dual this HER2 blockage has been done with trastuzumab and lapatinib. It is feasible, but the patient I had seen had a severe cardiac toxicity, so it was stopped.
Rishabh sir, I have one question. Sir, pertuzumab data in metastatic was mainly in the first line. Like how comfortable we are using pertuzumab whenever patient is not using in the first line. Patient progressed on second and third. How comfortable we are using in pertuzumab in second or third line or fourth line?
No. So see, this is a desperate situation where we don't have
Sir,
data for it. So
not
that's
in this,
well sure.
not in this other any cases.
So generally, say means this is my opinion. Suppose a patient has received trastuzumab prior in adjuvant setting or so, uh, and patient is rechallenged for metastatic setting and has good response to trastuzumab, then that is the ideal situation where you can add pertuzumab. But as you said that in second line or third line or fourth line, uh, we have data only to rechallenge trastuzumab. I don't think we have data for giving pertuzumab beyond progression on trastuzumab, like pertuzumab with some other than trastuzumab that we have not. We don't have any data in general. We won't use. Now, if
Sir,
someone has
request
received,
you to conclude your panel discussion.
sure. This is the we can keep this as last slide. So what we can say that if someone has received trastuzumab, then capecitabine, lapatinib for whatever reason, and there is a good disease-free interval, then probably when you are re-challenging trastuzumab, then probably it still makes sense to give pertuzumab, though it is second line. But if you
Yeah,
have
but I will
given
also like
trastuzumab in
to say,
metastatic setting and then you are giving K-PLEP and then TDM1 and then giving Trastu plus Per2, then it would be, I'm not sure whether that will help or not.
yeah, I'll also like to add if the there is definitely not there is no data for second line or third line addition of trastuzumab and pertuzumab, but first line trastuzumab pertuzumab is there only because it is the best therapy available for the metastatic HER2 positive disease. So even in this case, when there are no further options available with us, capecitabine and lapatinib is gone, TDM1 is gone, and if patient can afford
Yeah, so this
pertuzumab,
is a
then
desperate
I will
situation.
definitely
That
like,
is what
yeah.
we discussed. That this is a
Hello, sir.
desperate situation. So I think
Kindly
we will
conclude in
conclude.
2 minutes.
Yeah, we will conclude. So we'll not take the third case. We can conclude. Thank you all the panelists and thank you Tarachand once again for this opportunity.
Thank you, sir. Thank you for the excellent panel discussion. Thanks to the moderator and the panelists. As we move on, the session is sponsored by AstraZeneca, and I would like to invite Dr. Preeti Agarwal for her talk. Over to you, ma'am.
Thank you. I just share my slides.
Sure.
Okay, my slides are visible.
Yes, ma'am.
Okay, so let me start. Thank you, Dr. Tarachan, for giving me this opportunity to speak about HER2-positive metastatic breast cancer. So today I will discuss evolving trends in management of HER2-positive metastatic breast cancer. So the outline of my presentation is I'll discuss the introduction of HER2-positive metastatic breast cancer, then unmet need in second-line HER2-positive metastatic breast cancer, recent advances, current treatment algorithm, and finally I'll conclude. So introduction of HER2-positive metastatic breast cancer. As we all know, breast cancer is the most common cancer we have worldwide. Almost 30% patients of breast cancer will become metastatic after diagnosis. HER2-positive breast cancer constitutes almost 15 to 20% cases of breast cancer. So HER2 positivity not only confers the aggressive behavior of breast cancer, but also gives us an opportunity or target to have some targeted therapy. So this is the timeline for FDA approvals of HER2 targeted therapies in breast cancer. So trastuzumab was the first targeted therapy approved in 1998 in metastatic setting, and it took almost 8 years for trastuzumab to be approved in adjuvant setting. In 2012, we had pertuzumab. Later, now in 2019, we developed antibody drug conjugate TDM1 and TDXD with the newer tyrosine kinase inhibitors like lapatinib, niratinib, tucatinib, and so on. So this is HER2 signaling pathway. HER2, after activation, dimerizes with another molecule of her family like HER1, HER2, or HER3, and it sends downstream signaling, either activating RAS, RAF, MEK, ERK pathway or PI3K, AKT, mTOR pathway, causing cellular proliferation, invasion, and survival. So this is mechanism of different HER2 blockade. Trastuzumab inhibits HER2. Pertuzumab, it inhibits dimerization of HER2 with other HER family like HER1, HER2, or HER3. TDM1 or TDXD are antibody drug conjugates where they bind to the HER2 receptor and internalizes the payload which is attached with the antibody with linker. So discussing the unmet need in HER2-positive metastatic breast cancer. So it is important to see that after first-line therapy, only 78% patients receive any therapy in second-line setting, and out of which only 2/3 of patients will receive any treatment in third-line setting. So it is important to use the most effective anti-HER2 therapy or chemotherapy in first-line setting so that most of the patient get benefit of the most effective therapy. Because almost 1/3 of the patient will not receive any treatment in third-line setting. So these are key data for supporting existing therapies in metastatic breast cancer. In first-line setting, we have Cleopatra data, where addition of pertuzumab to the chemotherapy plus trastuzumab arm improved overall response rates, improved median progression-free survival from 12 months to 18 months, and overall survival from 40 months to 56 months, with similar grade 3 adverse events. In second-line trial, the key second-line trial we had is Emilia trial, where lapatinib plus capecitabine was compared with TDM1, which is antibody drug conjugate, which showed an improvement of progression-free survival by 3.2 months and overall survival by almost 6 months. So median progression-free survival, it is important to see that median progression-free survival drops almost half from first line to second line setting as we see. So we can see that median progression-free survival with trastuzumab, pertuzumab, and docetaxel arm was almost 18 months, which dropped down to just 9 months with TDM1 in second line setting. So as we proceed, the median progression-free survival drops down as we move from first line to second line to third line setting. So both Cleopatra and Emilia trial was done in 2012 and what was done simultaneously. And there is no study of randomized control trial of TDM1 post trastuzumab and pertuzumab. The only trial is after only trastuzumab. There are only just real world evidences of adding second line post trastuzumab and pertuzumab, and where we find that median progression-free survival is actually inferior in patients who receive TDM1 post trastuzumab and pertuzumab. There are two real-world evidence data where they see that after prior exposure of pertuzumab, the TDM1, the median progression-free survival of TDM with TDM1 is just 3 months. But compared to the patients who did not receive pertuzumab previously, it was 8 months. So, prior pertuzumab exposure actually reduces the median progression-free survival in second-line TDM1. So this is because there is a decrease in HER2 expression post pertuzumab, and the DM1 molecule, which is linked with trastuzumab in TDM1, does not have any bystander effect because it has very low permeability to the surrounding cells. So, what recent advances we have in HER2 positive metastatic breast cancer? The recent advance is now with TDXD. TDXD is an antibody drug conjugate where the molecule payload is a topoisomerase 1 inhibitor in a ratio of 8:1 with a cleavable linker. What happens is it binds to HER2. This antibody drug conjugate binds to the HER2 receptor. It causes internalization of TDXD molecule. The linker is cleaved, and this topoisomerase 1 payload is this topoisomerase 1 payload is detached from the linker, and it goes inside the nucleus and inhibits the topoisomerase, and it has good permeability, and it affects the surrounding cells as well. And in multiple trials, it has shown a response rate of almost 60%. So difference between the two antibody drug conjugates, TDXD versus TDM1. The payload monoclonal antibody with TDXD is topoisomerase 1 inhibitor, while it is microtubule in TDM1. The drug ratio is 8:1 compared to 3.5:1 in TDM1. So there is tumor selective cleavable linker in TDXD while it is not absent in TDM1. And there is bystander effect with TDXD because of the higher permeability while it is absent in TDM1. So this is a Destiny phase 1 trial, open label multicentric phase 2 study of with prior exposure to TDM1 in patients. We can see the median progression-free survival for almost 16.4 months with TDXD and overall survival not being reached. The another trial is Destiny Breast phase 2 trial. Destiny Breast 2 trial, it is a phase 3 open label multicentric study where patients with HER2 positive metastatic breast cancer with prior progression on most of recently received treatment and previously treated with TDM1 were randomized in 2:1 arm to TDXD at a dose of 5.4 milligram per kilogram every 3 weekly versus therapy of physician choice. The primary endpoint was progression-free survival, and the key secondary endpoint was overall survival. So we can clearly see the separation of graphs with the median progression-free survival of TDXD in third line setting after progression on TDM1 was 18 months, almost 18 months, 17.8 months, while it was just 6.9 months with therapy with physician choice. So the 12-month PFS rate was almost 62% with TDXD, while it was just 27% with therapy of physician choice. Similarly, overall survival was improved from 26.5 months in patients with therapy of physician choice to 39.8 months with TDXD in third line setting. So, seeing this, Destiny Breast third study was designed, and where TDXD was upgraded to in second line setting in patients of metastatic HER2 positive metastatic breast cancer patients who had previously received taxanes plus trastuzumab were randomized to TDXD versus TDM1. The primary endpoint being progression-free survival, the secondary endpoint being overall survival. So both the arms were equally matched, and almost 57.1% patients in TDXD arm and almost 60% patients in TDM1 arm were Asians. And almost 25% patients, 24% patients in TDXD arm and almost 20% patients in TDM1 arm had history of brain metastasis. Approximately 60% of patients, each arm had previously received pertuzumab. So almost all patients had received trastuzumab previously, and almost 60% patients had received pertuzumab previously. This is an important point because we already know from real world evidence that after pertuzumab, TDM1 works less. So this is a median progression-free survival, which was almost quadrupled, like 4 times. The median progression-free survival with TDM1 was just 6.8 months, while it was 28.8 months with TDXG. We can see such clear separation of graphs. The median progression-free survival percentage at 12 months was 75% with TDXG, while it was just 33% with TDM1. At 24 months, the PFS rate was 53.7% with TDXG, while it was just 26.4% with TDM1. So similarly, investigator assessed PFS was similar to a blinded independent committee review, with almost quadrupling of the progression-free survival with TDXG. The other secondary endpoint being overall survival, which is not reached in both arms, but we can clearly see the separation of graphs. And even at 12 months, the OS rate was 86% with TDM1, while it was 94% with TDXG. While at 24 months, it was 69% with TDM1, and it is 77% with TDXG. So this is a subgroup analysis where we can see that TDXG is benefiting in every arm. Similarly, in progression-free survival, TDXG benefits every subgroup, like in hormone receptor positive, prior reception of pertuzumab, prior baseline visceral disease, prior systemic therapy, and baseline brain mets. These are the Kaplan-Meier curves in patients with or without brain mets. We can clearly see in patients with brain mets, the median progression-free survival was increased from 3 months in TDM1 arm to 15 months in TDXG arm, with such wide separation of graphs. Similarly, in patients without prior brain mets, the median progression-free survival with TDM1 was 7 months, while in TDXG arm it was not reached. This is a waterfall curves which saying the response rate of almost like the clinical benefit rate of 89% with TDXG arm, where it is just 46% with TDM1 arm, with overall response rate being 80%, almost 78.5% with TDXG arm, and 35% with TDM1 arm. Almost all patients are responding. So PFS2 and post-study cancer treatment. The median PFS2 in TDXG arm was 40.5 months, while it was just 25 months with TDM1 arm. Which says that PFS2 is also improved with after TDXG. So in TDXG arm, almost 64 patients or 35% patients received TDM1 post-progression, while in TDM1 arm, almost 20% patients received TDXG post-progression. So this is overall safety analysis. Almost 56% patients had grade 3 related drug-related adverse event, which is similar in both the arms. The most feared or most dreaded complication associated with discontinuation of TDXG is pneumonitis, which was seen in 5.8% patients, ILD, which was seen in 5.1% patients, and pneumonia, which was seen in 1.9% patients. While the most common complication with TDM1, which caused discontinuation of drug, was thrombocytopenia and pneumonia, which was seen in just 1.1 and 1.5% patients. So, although the rates of treatment-related adverse event associated with discontinuation were greater with TDXG compared to TDM1, exposure adjusted rates are generally similar. The other important events to note with TDXG is anemia, decreased platelet count, decreased WBC count, which was seen in almost 20% patients, and neutropenia, fatigue, nausea, and vomiting, which is also common side effects with TDXG. So I've already discussed almost 5% patients required discontinuation because of ILD, and almost 11 patients had grade 1, 26 patients had grade 2, and 2 patients had grade 3 ILD and pneumonitis because of TDXG. On overall, 15% patient had any grade ILD and pneumonitis because of TDXG. Concluding, TDXG demonstrated clinically meaningful, statistically significant improvement in overall survival compared to TDM1, as well as continued PFS benefit in patients who were previously treated with trastuzumab and taxane. So the median progression-free survival is actually quadrupled from 7 months to 28 months, with overall response rate being almost 80%. with overall survival observed across all pre-specified groups. Updated results demonstrate remarkable OS and PFS benefits with TDXG and further supports the use of TDXG in second-line setting post-progression on taxane and trastuzumab. This is the updated NCCN guideline where the TDXG has actually improved from third-line to second-line setting. Now the TDXG has become a category 1 recommendation in second-line setting post-progression on trastuzumab and pertuzumab. So the take-home messages between first-line THP and second-line TDM1 treatment, the PFS numerically drops half from 18 months to almost 9 months. The current treatment paradigm for HER2-positive advanced breast cancer include THP followed by TDXG after progression as standard of care for initial treatment. Thank you so much.
Thank you, Preeti. Now I invite for the next session. We are moving towards the advanced ovarian cancer session, and I invite Dr. Amit Kumar, Medanta Hospital, Patna. He will be discussing recent trial of result from the randomized placebo-controlled phase 3 DOO trial. Amit, please.
Yeah, thank you, boss. Thank you for this opportunity. So I will be just sharing my screen. So the talk given to me is about the activity of immunotherapy and PARP inhibitor and VGF inhibitor, all along with chemotherapy in the ovarian cancer. So this is basically durvalumab with paclitaxel and bev, followed by maintenance durvalumab, bevacizumab, and olaparib in patients with newly diagnosed ovarian cancer, and that also in those without a tumor BRCA1, BRCA2 mutations in those group of patients. So basically, it is said that the maintenance therapy with olaparib and bev has improved outcome in the first-line advanced ovarian cancer. However, there is still an unmet need, especially in non-BRCA mutant patient subgroup. And to date, it says that phase 3 trials investigation the addition of immuno-oncology agents to standard of care in this newly diagnosed cases have yet to show any clinical benefit. But the phase 2 Mediola study earlier has shown that the combination of durva plus bevacizumab and olaparib has a promising clinical activity in those with non-germline BRCA mutation. And the phase 3 DUO study, this study evaluates this paclitaxel along with bevacizumab and durvalumab, followed by the maintenance therapy with bev, durva, and olaparib in patients with newly diagnosed non-BRCA mutant advanced ovarian cancer. And it's basically the interim PFS analysis which has been shown in this. So if to see the study design, it's all newly diagnosed stage 3-4 high-grade epithelial ovarian cancer with no prior systemic therapy for ovarian cancer, and PARP inhibitors, they are NAE for that, and primary debulking or planned interval debulking is planned, and they are non-BRCA mutant. It's late. And there are 3-arm study, 1:1 basically with chemotherapy along with bev in the first arm, with durva placebo they have taken. In the second arm, it is chemo with bev and durva to start with. And in second and third arm, both chemo, bev, and durva. And the maintenance phase varies. In the initial first arm, it is only bevacizumab for the 15 months. In the arm 2, it is bev and durva for bev for 15 months and durva for 2 years. And in the third arm, it is bev, durva, and olaparib, all for a total of 24 months. And the endpoint, if we say it is the PFS, is the initial endpoint in this study. And especially they have taken in the arm 3 versus arm 1. That is the arm with bev, durva, olaparib in comparison to only bev maintenance phase. And that too in the non-BRCA mutant HRD positive cases. And the secondary endpoints they have taken as a PFS, that is comparing the arm 2 versus arm 1 and OS and safety analysis. So what it is saying that they have taken a multiple testing procedures, a hierarchical testing they have taken for this evaluation. That is the primary endpoint with the 5% alpha error. They have calculated how the PFS has to be taken in arm 3 versus arm 1. In the non-BRCA mutant, basically HRD positive. Firstly, they have evaluated the HRD positive patient, and if it has come to be significant, then they have gone through with the non-BRCA mutant, non-HRD positive cases. That is the whole population, that is in the intention to treat population subgroup. So the plant sample size was something around 1104 cases, and the superiority interim PFS analysis was planned when 86% of the PFS events have occurred in arm 3 and versus arm 1 in non-BRCA mutant HRD positive initially patients, which comprises 128 PFS event, and intention to treat, it is something around tripling, that is 390 events they have taken. So the patient characteristics, as we see, it is more or less same, that the median age is around 60 years, and most patients were from Europe, and few were from North America and rest of the world, and maximum patient were of stage 3, 2/3, and stage 4 is 1/3, with the ECOG performance status maximum is of 0 or 1, that is varying from 65%, and maximum are high-grade serous tumors. Upfront surgery is done in almost slightly more than half of the patients. 60% of the patient has undergone upfront surgery, and the interval debulking in next 40% of the patients. And the patient is having a macroscopic disease, or no macroscopic residual is seen in around 40% of the patient. HRD positive status is 40% of the patient is HRD positive, and HRD negative, and the rest around 60% are HRD negative. So if we see if any treatment received any treatment or started maintenance phase, so almost all patients have received, 100% of the patient have received durvalumab if they are taking, and around 90% have received olaparib during their maintenance phase. And paclitaxel carbo plus bev, that is the initial chemotherapy, has been received by 100% of the patients. And at the time of study being continuation, around we will say 20% of the patients are still on therapy of these treatments. So it has been seen that across all the arms, something around 90% of the patient completed all planned cycles of chemotherapy. So there's only 10% to be drop out, 90% are found to be completing the all cycles. So the PFS, what we say, that is the non-BRCA mutant HRD positive population, that is the first PFS is in a hierarchical manner they have calculated on this. And they have shown that the median PFS is something around 37 months in the Durva plus Bev plus Ola maintenance phase, as compared to 23 months in the Bev maintenance only. And the 2-year PFS increases from 46% to 70%. That is around 25% improvement in the PFS in this group. And after that, the intention to treat population, that is the whole population, is calculated. And in that, they have shown that the median PFS has gone to 24 months as compared to 19 months in the only the Bev maintenance arm. And the 2-year PFS has increased from 32% to 51%. So this median PFS, if we see all the 3 arms, if it is being taken, that is even the patient who has only received Durva maintenance as compared to Durva plus olaparib maintenance. So that arm is all not showing a significant benefit to those of Bev, that is 19.3 months PFS was with Bev maintenance, and Durva plus Bev maintenance is something around 20.6 maintenance. And if we see the hazard rate, it is 0.87, but it is crossing 1. And in the arm 3, it is 24 months with a hazard rate of 0.63, and which is not crossing unity, so found to be a significant benefit as compared to arm 1. So the subgroup analysis of PFS by HRD status, if we see that is non-BRCA mutant HRD positive, shows a better benefit of around 37 months as compared to 23 months. And in HRD negative population also, if we see, if it just separate HRD negative from the HRD positive, it is 20.9 months as compared to the 17.4 months. So the HRD negative population is also showing a benefit clearly. The 2-year PFS increased from 24% to 40% in the HRD negative patients. So the non-BRCA mutation for all the 3 arms, if we compare, it is shown that if durvalumab is added in the HRD positive, it is still similar to those of with only Bev, that is 23 months versus.
Hello, sir. Sir, kindly conclude, please.
Yeah, sure. And those with without HRD negative, it is around we say that is 17 months as against to 20 months. So I'll leave this subgroup. The safety analysis, we'll say that the MDS AML incidence is only around 1% in this subset of the patient, not great. But the important thing is adverse event leading to discontinuation. So something around 35% of the patient in the maintenance Bev Durva Ola arm has to be discontinued therapy. That is the only thing we have to be taken consideration. Important. And the most common side effects are nausea, anemia, neutropenia, as we already see in different studies. So to conclude, DUO met its primary endpoint of the planned PFS interim analysis, and they have shown that the non-BRCA mutant HRD positive has a hazard rate of 0.49, and those in the intention to treat it is 0.63. So PFS benefit was seen across all the subgroups, including those patients with HRD negative in these groups, and safety was consistent as with the earlier trials. So the trial is ongoing. Final PFS, OS, and other key secondary endpoints will be reported in due course. So with this, I'd like to stop my presentation. Thank you.
Thank you, sir. For next talk, I would like to invite Dr. Ankur Punia, sir. Sir, please start.
मुझे भी आइडिया नहीं है और है ना अच्छा और है ना एक है ना इसको ये
Are my
नहीं
slides visible?
Yes, sir. So just make it full screen.
Are they full
Please
screen?
start, sir.
Yes. So good evening, everybody. So today I'm going to discuss about this OVO-HIPIC study. Basically, it's comparing cytoreductive surgery with or without hyperthermic intraperitoneal chemotherapy, HIPEC therapy, in patient with advanced ovarian cancer. So this is the final survival update of this phase 3 randomized study, which is presented after almost 10 years follow-up for the patients included in this trial. So what was the basic, rationale of this came into thing, that HIPEC thing? So ovarian cancer, the problem with ovarian cancer is most of the patients are diagnosed in advanced stage. Almost 70% of patients have some sort of peritoneal disease. You do any kind of therapy, still they have high recurrence rates and very, very low survival rates. So that's why HIPEC came into the picture. So it basically targets this resistant peritoneal disease because this is the most common site of relapse for these patients. It's an intraoperative procedure. We give a high concentration of chemotherapy directly at the site of the disease, and limits to an extent the systemic exposure and systemic side effects of these therapy. So what was the rationale behind deciding whether to give what kind of drug to be used for this HIPEC therapy? So the ideal candidate which was considered was whether to give what kind of platinum. The cisplatin is slightly considered better because of multiple factors. First of all, it's a more biologically active, it's a stable form, less toxic, it has a minimum local and systemic toxicity, and it absorbs, one of the most important things is it absorbs slowly from peritoneal cavity compared to carboplatin, so it was preferred. It has a synergistic effect with hyperthermia. It has adequate tissue penetration. So, preclinical studies and phase 1 studies showed that cisplatin is the ideal drug instead of carboplatin, particularly to use for intraperitoneal therapy per se. And we have multiple studies with intraperitoneal chemotherapy, and most of them also use cisplatinum only and not carboplatin. So this is the basic trial of this study scheme of this trial, OVO-HIPEC study, phase 3 study. Basically, they took patients with stage 3 ovarian cancer only. Stage 3 were taken. Patients were given 3 cycles of chemotherapy, paclitaxel, carboplatin, and then they were randomized. So 245 patients were taken. Then they were randomized between interval cytoreduction versus cytoreduction plus HIPEC therapy, and then followed by that 3 cycles further of chemotherapy was given. Primary endpoint was RFS and secondary endpoint was OS, safety, and QOL. So the primary analysis of this study was published almost 4 years back after a 6-year of follow-up in the NAGM, and it showed a clear-cut difference that PFS was improved 14 versus 10.7 months, OS was improved 45 versus 34 months. So remarkable improvement by adding the simple surgical procedure during surgery, which we do routinely. So what I'm going to discuss now is the long-term, almost a 10-year update of this trial. So this is the only phase 3 trial, the biggest trial of the HIPEC study, which has been reported positive, and recently a Korean trial was also reported. So this is the 10-year PFS. We can see that benefit is maintained for these patients even at 10 years. PFS was similarly 14.3 months versus 10.7 months at 10 years. And it's sort of well maintained after, you can see 3 years. PFS patients benefited, they continue to benefit from the addition of this surgical procedure. Similarly, if we see the OS benefit, again the same thing, OS benefit was maintained for a long period of time. Similarly, shows that 10-year OS was 45 versus 33 months, a remarkable difference of around 11-12 months, which is a big thing for such a small procedure which can be added for these patients. And we look at this all the subgroups which were taken. So majority of the subgroups, whether they are more than 65, age was whether they have another histology, though the patient's number were very low, most of them were high-grade serous, whether patients had a previous suboptimal cytoreductive surgery, our number of involved regions were involved, whether laparoscopy was done or not. Almost all the subgroups benefited. Only one single subgroup which didn't benefit was the BRCA, mutated patients. But the number were low. Maybe some hypothesis generating thing that maybe PARP inhibitor, use of PARP inhibitor was able to overcome the deficiency of HIPEC. So similarly, we see in the OS as well, the same thing. Most of all the subgroups had a benefit irrespective of type of age, type of tumor, whether optimal cytoreductive surgery was done or not. Again, the same thing in the germline BRCA mutated patients. These patients more or less didn't benefited much from the addition of HIPEC therapy. So what kind of subsequent, if you look at the subsequent therapies, because this is a very long-term 10-year follow-up, majority of the patients, we can see 80-85% of patients received subsequent chemotherapy. Similarly, in both the arms, around 10% of patients in both the arms underwent some sort of secondary surgery as well. Majority of the patients, again, similar number of patients received eventually targeted therapy. So subsequent therapy, you can see are pretty much well balanced between both the subgroups. It was not like that this one subgroup, got more of subsequent therapy, and both the groups got similar number of non-significant, I'll say, subsequent therapies. So various issues were raised because of the HIPEC. It's like various issues were raised when this first study was published in NAGM. That is study took very long to accrue. There was a selection bias, endpoints were not valid, taking RFS, length of the survival in control arm is not that much good, sample size is small, groups are not balanced, it's an open label design, toxicity is not reported, and again, cost. But as time we have seen clearly that it does not affect the quality of a trial. External validity has been done in multiple studies. As advocated for the time of design of the study, endpoint was pretty much is taken all the trials, the RFS endpoint, and a difference of 3 patients, whether they were, most of the studies take majority have high-grade serous. So more or less, this was a very positive study. And one of the biggest, I will say, outcome booster for these patients, with a very small investment, and we can improve the outcome very much for these patients, because in India, we see majority of these patients with advanced age, I'll say more than 90% of patients come with a peritoneal disease. And one more important thing, they got a central blinded radiology review was done, because the peritoneal recurrences was thought one of the things that they can be missed by somebody, because this is the most common site of recurrence. So central radiology review showed a similar thing. The PFS difference was similar, even if it was centrally reviewed, and it was more or less same between 14 versus 10 months. So again, it showed that HIPEC benefited, even if you can see by different radiologists. But now we have to understand, HIPEC is not a single answer. Now we have multiple options. So optimally, utilizing these options and optimizing when to use what is the best strategy to improve the outcome for these patients. So yes, chemotherapy we are doing, cytoreduction we are doing. We have to decide in MDT, but HIPEC is now coming in a big thing. I think in the coming years, we might get more and more evidence regarding the use of HIPEC. So to conclude, for patient, HIPEC can be used as a standard therapy for stage 3 ovarian cancer patients who is undergoing interval cytoreduction. For stage 4 patients, we don't have any data because only stage 3 were taken. Similarly, for primary CRS over HIPEC 2 study, and 2 studies are going on. CP was recently reported, though a negative study, but we are awaiting results for 2 other studies. And similarly, for recurrent disease, we have multiple studies going on which might tell us more about these different kind of subgroups. Thank you.
Thank you, Ankur. Now I invite Dr. Deepak Shuklavas for a discussion of final overall survival results from the Paula 1 or Angot O2 Shield.
Thank you, Dr. Tara. I'll share my slides. So is it okay? Are the slides visible?
Yes, sir. Yes. Please start.
Okay. So I'll speak on the final overall survival of this Paula 1 trial. So this trial previously showed a significant PFS benefit of the use of olaparib with bevacizumab as compared to placebo bevacizumab in patients who were in complete remission or who have responded to platinum-based chemotherapy. The previously reported hazard ratio was 0.59, and in patients with HRD positive tumor, the hazard ratio was 0.33. And this is the final analysis that was reported last year with a 5-year follow-up. So this is the trial design. This was a randomized placebo-controlled phase 3 trial for patients with newly diagnosed Vigo stage 3-4 high-grade serous endometrioid ovarian fallopian tube or primary peritoneal cancer. These patients were to be in partial or complete remission after upfront or interval surgery and should have received platinum taxane based chemotherapy with at least 3 cycles or more during of bevacizumab with chemotherapy. So close to 806 patients were randomized 2:1 to the experimental arm of olaparib with bevacizumab. Olaparib was given for period of 2 years while bevacizumab was given for 15 months, the period including that was given along with chemotherapy, and it was compared to the standard of care placebo with standard of care bevacizumab with placebo for 2 years. The primary endpoint was PFS and the OS was the key secondary endpoint. So if we look into the disease characteristics, so approximately 50% patients in both arms were HRD positive. Approximately 20% patients were HRD positive, excluding tumor BRCA. 50% patients had upfront surgery. 42% patients approximately in both arms had interval cytoreductive surgery, and 7 to 8% patients did not undergo surgery. And the patients at the time of enrollment were either in CR or partial response in nearly half of them, while there was no evidence of disease in nearly 50% of the population. So previously at the 5 years, so the ITT population, the overall survival rate was 47.3% for olaparib bevacizumab as compared to placebo bevacizumab. But if we look into the OS in terms of the patients who were HRD positive, so the patients who were HRD positive, the 5-year overall survival rate was close to 66% with the use of olaparib with bevacizumab as compared to 48.4% in the placebo plus bevacizumab arm. This benefit was seen in spite that close to 50% of these patients in the placebo arm went on to receive PARP inhibitors. The median overall survival was close to 75.2 months with the use of olaparib bevacizumab combination as compared to 57.3 months in the placebo plus bevacizumab arm. The PFS benefit continued to be impressive. So close to 46.1% patients were progression free at 5 years in the olaparib or bevacizumab arm as compared to 20% in the placebo plus bevacizumab arm with a hazard ratio of 0.41 favoring olaparib bev. If we look into the benefit, so the majority of the benefit was driven by the HRD BRCA mutated patient. So we see that at 5-year overall survival rate of close to 73.2% in the BRCA mutated population with use of olaparib bev as compared to 53.8% in the placebo arm. The benefit was still seen in the patients who were HRD positive, even without BRCA mutation. So the 5-year overall survival rate here was 54.7% as compared to 44.2% in the placebo arm. And in the HRD negative, the last graph, if we see, in fact, there was olaparib bevacizumab had numerically detrimental survival in the HRD negative patients when the combination was used. And with the longer follow-up, it was again reassuring that fewer nearly comparable patients in placebo as well as olaparib arm developed any form of MDS, AML or aplastic anemia. The event rates were low. Also, new primary malignancy rates were comparable. So to conclude, with the extended 5-year follow-up, the clinically meaningful OS benefit was observed in HRD positive patients with newly diagnosed advanced ovarian cancer with the use of olaparib bevacizumab maintenance as compared to placebo bevacizumab. The 5-year overall survival benefit in was 65.5% as compared to 48.4%, observed even when the 50% of the patients in the placebo arm having received a PARP inhibitor, and benefit was observed regardless of the BRCA mutation status, though the magnitude of benefit was more in the patients who were HRD positive BRCA mutated. There was similar overall survival results in the HRD negative subgroup, and there were no new safety signal. So based on this, we can conclude that olaparib with bevacizumab is a standard of care for HRD positive patients. However, it is a different discussion whether for HRD positive BRCA mutated patient, do we need to offer bevacizumab at all, or we can give olaparib alone. So this is one of the standard of care and need to be discussed in our day-to-day practice. Thank you.
Thank you, Deepak Bose. And Deepak Bose, in which patients we are adding bevacizumab if the patients are non-metastatic?
So patient who are means having gross residual disease, possibly more than 1 centimeter residual disease or any residual disease or stage 4 disease. As such, personally speaking, I don't use bevacizumab very much, means in adjuvant setting per se. So mostly my understanding of what I practice is possibly if a patient is BRCA mutated, tumor BRCA positive or germline positive, I'll offer olaparib maintenance alone rather than combination of bevacizumab. For though I am aware that we have these discussions previously also that adding bevacizumab is a different discussion as compared to adding olaparib. So as mentioned, these are the few patients where I'll consider adding bevacizumab.
Yeah, because in ICON 7 there is a after the primary cytoreductive surgery more than 1 centimeter and pleural effusion was the criteria. Okay, boss. Thank you. Thank you very much, boss. And now I invite Dr. Mukesh Rolania for the next talk on optimizing outcomes for patients on Lynparza, efficacy, safety, and adverse event management. Mukesh, please.
So thank you, boss, for talking today. Can my slides are really visible?
Yes, I think this is your slide. Make our first count.
Yeah.
Yeah, please.
So in last 20 minutes, I will discuss about safety profile of olaparib in ovarian cancers. So what is the optimizing outcome for patient on olaparib? So agenda of this topic is safety profile of olaparib in the SOLO-1 trial, management of outcome of commonly reported adverse events due to olaparib combination with bevacizumab as discussed, olaparib adverse event management strategy, and then I will conclude. So SOLO-1 study that showed this study we show that this is a standard of care in advanced ovarian cancer. This study include newly diagnosed advanced high-grade serous or endometrioid BRCA mutated ovarian fallopian tube or primary peritoneal cancers who have completed primary or interval debulking surgery, and the patient have clinical complete response or partial response after platinum-based chemotherapy. Then they randomize patient to olaparib versus placebo, and they assess primary endpoint and secondary endpoints. So what are the various adverse events management flow to patient treated with olaparib tablet within the SOLO-1 trial? One is continue olaparib with supportive treatment, dose interruptions for severe adverse events for a maximum of 14 days, and then resilience at same dose, If a patient again develops side effects, then again dose reductions, 300 mg to 250 mg BD. Further reduction from 250 to 200 BD. That is minimum dose. If patient does not tolerate 200 mg BD, then treatment should be discontinued. So majority of patients remained on starting dose throughout long-term maintenance treatment during solo one. So this graph shows that olaparib dose reduction in solo one study is very less in majority of patients, and majority of patients are maintained throughout the study with 300 mg BD. So what is the most common side effect reported in patients on olaparib in solo one? But GI disturbances and anemia. Fatigue. So nausea is the most common side effect reported in the Solomon study, followed by fatigue and asthenia, then vomiting, then anemia, then diarrhea. So management and outcome of the most commonly reported non-hematological adverse events, as I so that majority of patients develop nausea, fatigue, vomiting, and anemia. So and these effects usually occurs within 1 month, and then they stabilize within 2 to 3 months. Nausea and vomiting in solo one generally reported early on, with most patients remaining on treatment. So prevalence of nausea over time with olaparib treatment. Nausea was generally an early event, and the majority of cases resolved without need for dose adjustment. No patient required dose adjustment due to only nausea. Again, coming on vomiting, around a quarter of patients who experienced vomiting required a dose interruption only, but only 2 patients had to discontinue it due to these adverse events like vomiting. So this is again very minimal number of patients. So how we manage nausea and vomiting? Reassess patients that nausea and vomiting usually improve within 4 to 8 weeks. At first occurrence, introduce anti-emetic therapy. Have patients eat something light before and when taking olaparib. If patient have nausea or vomiting occur despite anti-emetic therapy, interrupt treatment temporarily, approximately 1 to 2 weeks, and then restart at same dose. Again, if nausea and vomiting persist, then interrupt treatment and restart it at lower dose. And as I discussed, nausea is generally low grade, intermittent, and self-limiting after 1 to 2 months. 63 of patients in the olaparib arm reported fatigue. The majority did not require any intervention to remain on treatment. So fatigue, again, this is manageable. Majority of patients required only just supportive treatment. Some patients required dose interruptions, and very minimal number of patients required dose discontinuation. So how we manage fatigue who are on olaparib? Supportive care to cope with fatigue, such as strategy to conserve energy and exercise. Advise patients that fatigue is a common side effect and generally improves over times. Non-pharmacological treatment like afternoon nap to combat fatigue during the first 4 to 6 weeks of treatment. Exercise, refer to exercise physiologist, may be beneficial. Dose interruptions, if fatigue persists, then restart olaparib at same or sometimes at reduced dose. Again, anemia was the most common hematological adverse events experienced by Lynparza treated patients, and approximately 6% of patients discontinued due to these adverse events. And prevalence of anemia over time with olaparib. Again, I showed if anemia occurred initially, then that is maintained. That does not gradually progress during course of the olaparib treatment. So management and outcome of the most commonly reported hematological adverse events. Majority of patients required only just supportive treatment or blood transfusion, sometimes erythropoietin therapy. Some patients require dose interruption for some duration. Some require dose reduction, and minimal number of patients required dose discontinuation due to olaparib, due to anemia in olaparib arm. Some patients require dose discontinuation due to neutropenia. Some patients require due to thrombocytopenia. And majority of these adverse events are usually grade 1 and 2. So how we manage hematological toxicity due to olaparib? First, prior to treatment, patient counseling regarding frequency of hematological side effects, baseline testing of blood counts, ensure recovery from any existing hematology toxicity caused by previous chemotherapy. After starting treatment, monthly assessment of CBC for the first 1 year. Treatment-related anemia may be managed with transfusion without interruption of olaparib. For grade 3 and 4 adverse events should be managed by dose interruption. For prolonged hematological toxicities, interrupt treatment and monitor CBC weekly until recovery. If the level have not recovered to CTCI grade 1, after 4 weeks, refer to patient to hematologist for further investigations. So, what are the summary from this Solomon study? Olaparib monotherapy has been associated with adverse reaction generally of mild or moderate severity, CTCI grade 1 or 2, and generally not requiring treatment discontinuation. Most frequently observed adverse reactions, usually in clinical trials, who are receiving olaparib monotherapy, were nausea, fatigue, dysuria, dizziness, anemia. Grade 3 or more adverse events occurring in more than 2% of patients were anemia, neutropenia, and fatigue. Adverse events that most commonly lead to dose interruption or reduction were anemia, then vomiting, followed by nausea, and then fatigue. Adverse event that leads to permanent discontinuation was anemia, followed by nausea, and then thrombocytopenia. Again, this Paula study, Ola with bevacizumab, olaparib maintenance in newly diagnosed advanced ovarian cancer patient treated with chemo with beva. Sorry. The adverse event profile of olaparib in Paula 1 was consistent with previous trials of olaparib. So adding bevacizumab to olaparib does not increase toxicity. Again, this is hematological adverse events were consistent with previous trials of olaparib. No new cases of MDS, AML, or aplastic anemia were reported in an updated analysis. So summary, olaparib, adverse events with olaparib and bevacizumab were generally mild to moderate and manageable through dose adjustment. Adverse events profile of olaparib in Paula was consistent with previous trial of olaparib. After 5-year follow-up, the incidence of MDS, AML, aplastic anemia in the olaparib and bevacizumab arm remained constant with the primary analysis approximately 1.7%. So, one question to Taras and Bose. What are some of the challenging adverse events in your clinical practice with olaparib you observe in your clinical practice, which are difficult to manage?
Most important is the fatigue, and second one is the anemia. The most common is the anemia, which causes the down dosing of olaparib in most of the patients.
So how you manage fatigue in these cases?
Just other measures we use that. Please start some exercises and improve the nutrition by frequent meals and oral liquids, and take a rest of 30 minutes in a daytime. And for the anemia, we have to find out the cause if there is other than olaparib by the anemia profile, and if there is no other cause, then we transfuse the blood. And then if it is recurring again and again, then we down the dose by every time 1 tablet, that means 150 milligram. So most of the patients are on 3 tablets in a day, that means 450 milligram. Some patients are well tolerating on 600 milligram, and one patient is only on 300 milligram daily.
Okay, nice. So how frequent time you recommend exercise to combat fatigue, and what are any guidelines to how many times patient required exercise to combat fatigue?
No, there is no guideline from any medicine, but for the fatigue management, there is a strict guideline. If there is no other cause of fatigue, no identifiable cause, then the exercise and nutrition are the measures which can improve the fatigue only. These are the only two evidence-based measures. Other medicines are not effective in improving fatigue.
So, any patient require dose reduction or discontinuation due to fatigue only?
Yeah, I think one patient was there out of 8 to 10 patients that required the dose down dose because of the fatigue.
Thank you, Darabos. So you usually follow the fatigue is most common.
And one thing, usually we say that the nausea is the most common side effect, but I have not observed. I have asked patients many times, but there was no nausea in patients.
Yes, same here. So nice to talk you. Then how we manage again olaparib adverse event management strategy, supportive treatment, quickly through fast 8 to 12 weeks because fast 8 to 12 weeks is difficult. Then patient is symptomatic usually. So manage patient expectation, pre-treatment expectation, then reduce impact of adverse events, then proactively monitor for adverse events, early interventions, manage low-grade adverse event by only symptomatic treatment. And if patient have high-grade adverse events, then dose interruption and dose modification if patient required. So I discussed the patient have severe side effect down dose interruption and initially then patient can be required dose interruptions. So this is again I just discussed a patient, a 79-year-old patient, non-case of BRCA, one mutation, declined RRS BSO 10 years ago, then presented in late 2013 with abdomen distension and pain, gross ascites, large abdominal mass, and right adnexal mass 8 centimeter, high-grade serous cancer on biopsy, CA125 1980 unit per ml. Patient received 2-cycle paclitaxel carboplatin and then undergo interval debulking surgery. Come out on high-grade serous cancer for additional cyclopaclitaxel with carboplatin. Required 2 packed cell for symptomatic anemia, pre-cycle 6. Then CA125 normal at cycle 3. CT scan complete response after completion of chemotherapy. CA125 again normal. Then in March 2014, solo 1 trial progress because randomized maintenance treatment olaparib. Then progress on therapy, hemoglobin 10.2, 7.5, 6. Hemoglobin dropped from 9.8 to 9.8. Then again anemic 6, 7.4, 2 units packed cell again transfused. Restarted olaparib. Then again anemic 7.8. Once again 2 unit packed cell transfused. Dose reduction to 250. Then hemoglobin stable and patient well. So again, discontinuation is the last option. We consider support treatment as much possible. In January 2015, in this trial, hemoglobin 7.6, transfusion again 2 unit packed cells, olaparib reduced to 200 mg/d. Again, March 2015, hemoglobin 8.4, 14 days break and hemoglobin come up to 10. Completed 2 year maintenance, March 2016, April 2016 year, this hemoglobin 11.5. So this is course of these patients just for representation, representation only. And this shows that sometimes required blood transfusion only, sometimes dose reduction of olaparib due to anemia only. So this is again Tara was discussed that dose reduction how we can follow usually initially, and then again if this patient remains well age 85, last due on this CA125 normal, hemoglobin normal, CT scan normal, continue on surveillance almost 6 years from presentation with stage 3 high grade serous ovarian cancer. So long term survival is possible if patient can tolerate this mild type of side effect with olaparib. Thank you. Over to you.
Thank you, Mukesh, for guiding them how to manage the adverse event of olaparib. It will be helpful in our day-to-day practice also, because the olaparib is the drug of choice in BRCA positive patients in a first-line treatment of CA ovarian. So now, ladies and gentlemen, and the esteemed speakers, on behalf of the organizing committee of this today's Revolutionizing Oncology with Pathways to Progress, I extend heartfelt gratitude for your participation in the today's session on the breast and ovarian cancer. Your insights and shared knowledge have illuminated our path towards a better understanding of these critical issues. Let's carry forward the momentum gained here to make studies, make strides in research, support, and awareness. Thank you for your dedication to the fight against breast and ovarian cancer. And I also am thankful to our pharma partners, Dr. Reddy, AstraZeneca, Merck, Mankind, and Freshness Kavi, and Torrent Super Specialties, Pfizer, and Zydus. I also thankful to the Horizon team for smooth for conducting this today's session smoothly. Thank you. And we will we take and
Thank you,
bye-bye,
sir.
and we will meet tomorrow for the GI and prostate cancer session. Thank you.
Yeah, thank you everyone for joining. Thank you, sir. Thank you all the panelists, moderator. Thanks to my colleague Gitika and Garima. Thank you, sir. Till we meet tomorrow. Good night, everyone.
Good night.